Good morning. Today's discussion is going to be on neuromuscular blockers. This is something you're going to be using every day. What I'm going to try to do is cover this material first, which is the basics, and then I'm going to go into monitoring a little bit next. If we don't get into it, we'll get into it next week. So, what we're going to do with this discussion is first go over some of the basics, go over the neuromuscular junction once again, then talk a little bit about pharmacokinetics, go into very briefly into the history, clinical uses, some structure-activity relationships with these medications. Then we'll split it up into depolarizing and non-depolarizing agents. The non-depolarizers will be broken down into the two family groups with aminosteroidals and the benzoisoquinolones. Now let's go back to the basics, which is basic physiology, and that gives you an understanding of how neuromuscular blockers will actually work. Neuromuscular transmission initiates in the spinal cord and the alpha motor neurons. This sends a signal directly via one single axon to individuals' muscle spindles. This requires a myelinated fiber that goes a fairly long distance, and it uses the main neurotransmitter as acetylcholine. The receptor that's located postsynaptically is a nicotinic acetylcholine receptor that is a sodium-gated channel. Okay, so it's a ligand sodium-gated channel, which when the acetylcholine binds to it causes the sodium channel to open and to allow sodium to rapidly enter the cell and depolarizes it. Okay? Normally, the distance between the synaptic cleft is actually very, very small. It's only 20 nanometers in distance. And this allows for rapid transmission of the acetylcholine once it's released from the vacuole into the synaptic cleft, and allow for diffusion to be the main mechanism by which this acetylcholine then crosses over and binds to the actual receptors on the postsynaptic side, which is the actual muscle membrane. Acetylcholine is basically the main neurotransmitter. This is a nice picture showing you the actual setup. The alpha motor neuron, of course, is on the anterior horn. It sends a signal down with myelinated fibers, goes directly to each individual muscle spindle, and causes the firing of that muscle spindle and causes contraction. The good thing about this is that every single muscle in your body is innervated directly by the spinal cord. Okay? So that's actually an important concept, because it's not like the heart where you just have a syncytium of cells that all sort of work together. Skeletal muscle actually has to be individually fired to have the effect that you desire. Again, this is the actual artist rendition of the neuromuscular junction. It shows you that it has a high number of folds in it because that increases the receptor surface area. And this is where the vacuoles will empty and allowing the acetylcholine to bind and come across. What you also have in this system is a T-tubular system, which sends electrical signal downwards, which then causes calcium to be released within the cell after the depolarization. And it's the actual calcium that causes the muscle to contract. It's just like the heart. You get some kind of form of electrical activation, but the actual contraction, initiation, and termination is due to calcium. Now, there's different kinds of cholinergic receptors that we've found in the last few years. Almost everywhere that you look in the old textbooks, you'll hear about the postsynaptic receptors, and that was what was thought to be the main mechanism. It still is the main mechanism by which acetylcholine crosses over and binds and causes agonistic activity of that sodium channel and causes a muscle contraction. These postsynaptic receptors can be blocked, and they are by the neuromuscular blockers, and inhibit the sodium channel from either opening, which is what's called a non-depolarizer, or they actually open and cause the depolarization to take place and basically inactivate the muscle as a consequence. Of greater importance in the last few years is this concept of presynaptic receptors. Okay? Presynaptic receptors are found on the presynaptic membrane, which is, in other words, on the neuron, okay? The alpha motor neuron. And this presynaptic receptor is very important because it's a negative feedback mechanism. It basically shuts down the release of acetylcholine vacuoles. These are calcium channel voltage-gated channel receptors that basically are inhibited by the binding of high levels of acetylcholine and then inhibit the release of the vacuoles. That's pretty interesting, okay, because then it begins to explain problems that we encounter when we use things like neostigmine. Why is it that when you give such a reversal agent, you actually have muscle paralysis? Okay, it also explains the other actions of muscle relaxants, which is not, they don't just solely bind to the actual postsynaptic receptors. If you give it in high enough concentrations, they also begin to act on the presynaptic terminal, either directly or indirectly by increasing acetylcholine levels to the point that it causes this negative inhibition. So it's something that's kind of important to think about as you again begin to understand this material, and it begins to explain a lot of clinical things that we didn't understand just a few years ago. There's also what's called extrajunctional receptors. These additional receptors located in the actual skeletal muscle. Normally, under human beings, extrajunctional receptors are very few and infrequent. In certain disease states, like anything that causes the neuron to be damaged, okay, or the nerve signal doesn't get there properly, or you have things like metabolic effects like burns, okay, those can actually activate the genetic of the skeletal muscle to increase its receptor count on the surface of the skeletal muscle. And it doesn't just it doesn't do this right at the neuromuscular junction, but actually spreads these receptors all over the muscle. These, some books are called neonatal receptors. The book, in this book, calls it fetal receptors. I've always known it as neonatal receptors, so I'm using that terminology, I'm sorry. But neonatal receptors is what they are, and what you get is an upregulation of these receptors covering the whole muscle. If you think about this, it's a way that the muscle is trying to get some kind of nerve signal. It's trying to find a signal coming at it. So when you cut away the signal, what the muscle will do automatically to try to locate the new signal coming in is it covers the muscle with this new receptors. The bad thing about that, and the very dangerous part about that, is that these increase in numbers of receptors, if you give a certain medication like succinylcholine, can cause massive depolarization and cause massive hyperkalemia to the point of a hyperkalemic cardiac arrest. So you have to sort of always remember anything that deafferents or loses the actual axon to the muscle will cause this effect. And it may cause a very, very serious response when you give succinylcholine. These are the extrajunctional receptors. This is a typical picture or artist rendition of what the neuromuscular junction will look like. We talked about this in your first semester. This is why it's all sort of feeding into now, into your next part, which is pharmacology. Remember we talked about how the vacuoles are actually made at the nerve body, which is way up in the spinal cord. And the vacuoles travel all the way down to the nerve ending. Once they reach there, they have plenty of acetylcholine molecules inside them. But what actually causes the effect of actually pushing the vacuole to the end of the terminal and release of acetylcholine into the synaptic cleft is due to calcium. Calcium is highly modulated inside the terminal end of the nerve ending. We actually have voltage-gated calcium channels out here that are responsible for calcium to enter. When the calcium enters due to depolarization of that axon, then you get the ratcheting effect on the actual microtubules, and that pulls the vacuoles across and basically then allows the exocytosis and release of acetylcholine into the synaptic cleft. Once the molecules of acetylcholine are released, it will then go by diffusion and bind to the acetylcholine receptors that are found in the actual skeletal muscle membrane. The skeletal muscle membrane will then have two binding sites for the acetylcholine, which are here. These are called the alpha sites. So the acetylcholine receptor, which is a nicotinic receptor, is a 5 protein subunit. It has two alpha subunits that are basically identical to each other. These alpha subunits is where the acetylcholine molecule will normally bind. It is also where all the depolarizers bind to. The depolarizers bind to the alpha subunits. The non-depolarizers may bind on the alpha units, but they act as a competitive inhibitor, versus the depolarizing agents act like agonists. Okay? And I'll explain that a little bit later here. The non-depolarizing agents will sometimes bind the alpha subunit. Some of them also will bind inside the channel. Okay? So there's different places for where the actual molecule will actually bind, and it will have different capabilities. Both binding sites have to be bound by the acetylcholine molecule for the sodium channel to open and allow the conformational change to take place. Now, what's interesting about this receptor has been found recently is that when it changes its conformation, it has basically two gates. It has a gate that's located on the upper surface here, and there's another gate that's down here. When a drug like a depolarizing agent like succinylcholine binds to this site, it causes both of these channels to open, both of these gates to open, and allows sodium to transfer into the cell. Within a few microseconds, the bottom gate closes. It's a voltage-gated effect. So once the cell depolarizes, the bottom gate will close. Okay? So that will allow the actual muscle to what? Repolarize itself. So succinylcholine is going to depolarize it, but the reason it cannot activate again is that the succinylcholine stays bound to the alpha subunits and it leaves the upper gate open. And as long as that upper gate is open, there will be no way of causing that gate to reopen, to restart and to be used again. Okay? You have to wait till the actual succinylcholine comes off and diffuses away for that gate then to close, and then it could be reactivated. Okay? So that's how succinylcholine works. The cations that are actually transfer across are mostly sodium. You do get some transfer of potassium going outwards initially, but very little because it's the amount of ion flux change due to sodium is pretty high. So that causes depolarization in the cell. Eventually the cell will repolarize itself by allowing potassium channels to leak potassium out of the cell, driving it back to its negative potential state. So it's a pretty important receptor. Your presynaptic neuromuscular receptors are basically located here. Okay? These are the calcium channel receptors. They are the ones that will be bound by excessive amounts of acetylcholine and will be inhibited. So they don't allow calcium to influx again. And as a consequence, guess what the vacuoles do? They just sit there. Okay, and nothing will happen. Now the action potential that you have is generated at the neuromuscular junction, but then the electrical signal is transferred down the sarcolemma, down to what's called the T-tubules, and when it goes down the T-tubules, it goes down next to what's called the sarcoplastic reticulum, which is where the calcium is located at inside the skeletal muscle. The skeletal muscle will then release, the sarcoplastic reticulum will then release the calcium into the cytosol, which will then bind to the tropomyosin complex and cause the muscular contraction to take place. Okay? So that's pretty much your whole cycle. So ultimately, sodium channels are what's important for causing the voltage, but what causes the actual contraction is due to calcium that's being released. Now, once the acetylcholine diffuses across the membrane, the termination of action is also by diffusion. But what would happen then is the acetylcholine molecule, if it's not reuptaken right away, would basically diffuse back and bind to another receptor and cause repolarization or depolarization to take place and another muscle contraction to take place. The way the body eliminates that problem is that it has an enzyme that's right next to the acetylcholine receptor. And that enzyme is embedded in the actual muscle membrane, and it's called the acetylcholinesterase. Okay? The responsibility of that enzyme is to break acetylcholine into acetate and choline. The acetate gets diffused back into your bloodstream and is reused partly by your liver. It's in some of the parts of metabolism. But the choline is the one that the body doesn't want to get rid of, and it gets reuptaken right away by the actual nerve ending. And you have mechanisms that are available at the nerve terminal that has special kinds of pumps that pulls the choline back in. And then there's other enzymes that will restructure and reform the acetylcholine, and so it reuses the materials. Okay? There's different kinds of poisons that can have different kinds of effects, which we'll talk about another time. But just understand for now that most of the termination of action is due to this acetylcholinesterase. It terminates the acetylcholine by cutting it into two different components and basically making it inactive. Once the inactivation takes place, of course, the charge goes back to its negative state. The calcium gets reuptaken by the SR, and that terminates the contraction phase for that muscle. Now, the way neuromuscular blockers work is they work to inhibit the neuromuscular junction. They can either do it by depolarizing it or not being a non-depolarizer. A depolarizer basically acts as a mimicker of acetylcholine, but remains on the alpha subunits for longer periods of time than the acetylcholine. And as a consequence, it basically blocks from further acetylcholine binding and causing activation. The non-depolarizing agents don't work that way. They work by being antagonists. Okay, so they're competitive antagonists. Now, if you made these agents to be non-competitive, which there are poisons that do that, then the muscle basically cannot reverse its action and the person dies. The good thing about the non-depolarizing competitive agents that we use is that we can reverse the effects. Okay? We can actually are able to push off the molecule. Now, we've come down to basically two basic families that actually support this kind of management, which is the benzoisoquinolones or the aminosteroidals. Okay? Those are the two major families that we're going to talk about. There's also other drugs, but we're not using them anymore, so they're not part of your exams, and I'm not going to ask you about them. Things like galamine, something like that, we haven't used in about 15 years. Now, what we do with these agents is that they're basically to weaken the muscle. And we can weaken it to the point that the person cannot move. Okay? And so it's really good to be able to facilitate on intubations. The reason they were actually designed was because ether was actually a very good agent. The problem with it was that it has so much effects on the sympathetic drive. To get the degree of muscle relaxation that you wanted out of it, you would suppress people that were very weak too much, and you would kill them in the process. So they had to find some way of actually relaxing the muscles without having that effect on the sympathetic system, which is what the neuromusculars tend to do for you. Okay, so it facilitates treatment for surgical conditions that are optimum. Okay? It doesn't mean that you've got to drive the person down to zero twitches all the time. It's not necessary in the operating room to do that. You have other agents that also help you, which is the volatiles, that will also suppress you to a very big degree, and then you can supplement them with the actual neuromuscular blockers. People are still making this mistake to this day. There's still a lot of practitioners right now that are using way too much muscle relaxation, and what the mortality on it is actually pretty high. People are not reversing people properly. They're not using their actual twitch monitors. There's a lot of problems still in clinical in the United States and pretty much in the world. So it's one of the things you don't want to get into a bad habits up front, because then you're going to get into trouble later on in your career. It will catch up to you. So it's also used to facilitate for critically ill patients to be placed on mechanical ventilators. The other thing that it does also in the ICU is that it decreases metabolic workload. It does that in the operating room as well, as you'll see soon enough. One of the things that I'll never forget. I always read this, and I knew this was to be true when I began to read this material, is that neuromuscular blockers have no effect on the brain. Okay, they have no effect on the brain. It does not cross into the blood-brain barrier. Okay, so the person is paralyzed, but totally awake. Okay? The first person that actually did this study was in the United States. Okay? He actually put himself on a table, okay, put an IV in himself, had 3 of his colleagues watch him, 3 of them, okay? And then he allowed himself to be injected with curare. Talk about insane, right? Okay? And he sat there for 45 minutes while they ventilated him. He said the most scariest thing about this was that he could hear everything, could feel everything, but couldn't move, and couldn't talk, and couldn't see what was going on. Pretty scary place to be. Okay? Imagine if you're a patient that you use this agent on them without telling them what was happening. It would be pretty scary. Okay? Now, I always thought this was pretty obvious. I thought, well, you know, everybody knows this. So I went up to Chicago, went to a major learning center, and I went downstairs to the ER one day to see what they were doing, because I was just sort of curious. I'd heard something that was kind of bothering me, so I just wanted to go see. And I saw an induction, and the induction was composed of lidocaine and Pavulon. That was their induction. And I was looking at this ER doctor that was doing this thing, and I told him, I said, do you realize that this person's not asleep? His first comment was, and she had great observational ability, was the patient's not moving. And I began to explain to him that's not the same thing as being asleep or induced. He said, well, the lidocaine does that. Okay? You're giving 100 milligrams of lidocaine. I don't think that's really doing that much. Okay? He says, I'll put an IV in me right now and give myself 100 milligrams of lidocaine to prove it to you. Okay? So, actually, the way I proved it to him is he didn't believe that. As I told the patient, I said, tell this SOB, and I told the patient, the doctor's name, that you're awake when you wake up in 2 days, when they allow you to wake up. Because we put the guy to sleep after that in the ICU. So sure enough, 2 days later, he was extubated, doing fine. He said, I'm going to talk to that doctor. And I sent him downstairs. And he told him all about our conversation, how I was basically telling him not to do certain things, and that opened his eyes up and made him realize. And he was actually teaching residences. It's really scary. Okay, so there's a lot of misunderstanding of what these drugs can do. So please be aware that just because you can paralyze somebody, it doesn't mean that it's a good thing. This is why we have awareness problems under anesthesia, is because these drugs are so potent. Yes? They can see, but it's very difficult for them to see. They can't focus. The ciliary muscles of the eyes, which gives you the ability to focus, are the first ones that get knocked out. So you'll be able to see black and white and see images coming in front of you, but you won't be able to focus. It's very disturbing. It also gives you a very high incidence of nausea and vomiting for that reason as well. And a lot of people don't think about that. They think that the reversal agents are bad. So they start not using them. The problem is they still have nausea and vomiting, but now their larynx is not adequately reversed, and now they're aspirating. Okay? So no agent's perfect. Okay? And I'm going to keep talking to you about that. So it becomes drilled in your head. There is no perfect agent. If it is a perfect agent, you know what? We'll throw everything else away and just use that. And guess what? We got a whole armamentarium. Why? Because nothing's perfect. Okay? You just got to realize when should you use it, why should you use it, how should you use it. Okay, the pharmacodynamics of neuromuscular blockers is that they basically bind to the acetylcholine receptor and they cause their effect. Either they do it by depolarizing or non-depolarizing. You need to monitor the degree of muscle relaxation. Basically, we'll be discussing in the next lecture. We'll talk about the different kinds of twitch monitoring. So hopefully you'll be able to understand a little bit about what twitch monitor really does. Not all neuromuscular sites act as the same, and that's really important for you to understand. The large muscle groups that are slow, okay, diaphragm, skeletal muscle, okay, tend to be more resistant to paralysis. Muscles that are fast, eyes, facial muscles, things that act quickly, tend to be more susceptible to a neuromuscular blockade. So from easiest to most difficult, the diaphragm is the most difficult to block. Then the hand one, the adductor pollicis, is next. And then the orbicularis oculi is next. Okay? And the book's got it in between here. And I tell you, laryngeal muscles tend to be in between this group. The book put it this way. I tend to disagree a little bit, but we'll sort of just leave it that way for now. We'll come back to that in a few minutes. But just remember that the diaphragm is the last one to go out, and it's also the first one to go out. Why is that important? Because if you begin to try to gauge muscle relaxation by breathing, you're going to be grossly mistaken. Somebody could be breathing just fine and still have their larynx completely out. So when you pull the breathing tube out, the larynx closes up, and that's it. Game over. Okay? You have to reintubate them. So just be aware that the diaphragm is pretty resistant to the effects of neuromuscular blockade, but you can shut it down with other methods. The diaphragm can be suppressed because you can suppress the central nervous system to breathe. So narcotics will stop diaphragmatic motion, and sometimes that's more appropriate than actually giving somebody a more neuromuscular agent at the end of the case. It's better just to add a little bit more narcotic, make the person not want to breathe, and then the diaphragm stops moving and then stops irritating the surgeon. Okay? So just be aware there's different ways of managing different problems. All the volatile anesthetics do potentiate the action of neuromuscular blockers. The way the volatile anesthetics basically do that is they affect sodium channels. Okay? So sodium channels are going to slow down the conduction velocity of the actual alpha motor neuron, and it's going to help you relax the patient more so. This is what I'm thinking here. This is how it shows you that the larynx is in between. The larynx tends to come back earlier in this chart, which is depending on which muscle relaxant you're using. And the adductor pollicis will come back a little later. So your larynx does come back a little bit sooner in this picture. So I don't know. There's differences in opinion on this. Pharmacokinetics-wise, pretty much all muscle relaxants that you talk about, neuromuscular blockers, are quaternary ammoniums. Okay? They have the N group with 4 different bonds to it, which gives it a charged state. And that's kind of good. If you make something charged, what does it not do? It doesn't cross the blood-brain barrier. Okay? So neuromuscular blockers don't themselves go inside your brain and bind to acetylcholine receptors in your brain. That would be devastating. That would not be a good thing. Okay? So for them to stick outside and be water-soluble is very important, but also they're very poorly lipid-soluble. So they don't enter into the brain. They don't enter the placenta very well. If you give, this is kind of important, if you're hunting with curare darts, and you're one of the Indians down in South America who first developed curare, if you shoot your monkey or you shoot your bird with a curare dart, it would be very bad if the muscle relaxant would go through your GI tract. It would paralyze you and kill you. Okay? But they know that they don't have to worry about it. They just can eat the animal, they cook it, and then they can have it without any problems because these agents will not cross the GI tract. Okay? It will not, because it's so highly ionized. And I was wondering how they ever figured that out. I guess they did it by trial and error, I guess. It's actually rather interesting how they make curare. It's actually made from a tuberous plant. When I was in the jungle in Panama, one day I was walking through one of the rivers, and I looked down, there was a bunch of dead fish in the water, and I started looking at it more carefully. And there was a tuberous plant that was actually going down into the water. And there was a small nick in it. There was this light white latex material dropping into the water, and it was killing the fish. I sort of thought about it, looked at it, said, that's different. I wonder what the heck that poison is. And then I just went back to my normal things that I was doing. It was many, many years later when I actually saw a picture of it. The same picture is what's called the tubercle curare. It's a tuberous material. It's a parasitic plant that lives off other trees. And it actually has tubers that drop down and usually go into areas of water. And the latex material that's in it is what's called, it has curare in it. And that's what dripped into the water and was killing the fish. But I'm sure somebody must have seen that, figured out it's good poison, and they used it. Okay. What's more interesting than that is that the actual fractionation method, the way they actually produce the curare, is very difficult. It isn't something that is just easy to do. You just can't take the latex off the plant and then use it. They actually go through a whole process. It's almost like a chemist is doing it. And it's like 5 or 6 steps to actually finally get the actual curare paste. The curare paste that was brought back to the United States was first used. It was basically looks like carbon. It's completely black. Okay, and they then isolated the material, which we call D2 curare, from that black paste and made it into a chemical, which is actually a white powder. Okay, but the actual Indians down in South America use this black paste that they roll onto their needles, or their darts. Okay, and they usually use a blowgun, or they can use arrows. Most of the time, they just use blowguns to work. And it works very, very efficiently at getting the actual monkeys. I used to see them shoot down howler monkeys down, which is pretty interesting. Big animal. Yep. Very good question. And the answer is nobody really knows. Okay? And I would suspect that it does go into the brain and will bind to certain portions of their brain. But usually at that point, they're so heavily sedated that you just don't know what the effects are. So it's kind of, you'll never really find out either, because you'll be paralyzing the individual and they won't be able to tell you what's really going on. There's never been any associated seizure activity, which you'd think it wouldn't be. If it does cross the blood-brain barrier, I would suspect that it's going to be acting more as a suppressor of the central nervous system. It's going to give you a more profound effect than you expect. So you might get more degrees of hypotension depending on where it bound. But nobody really knows that. Sometimes it's associated just with anaphylaxis. It may not be anaphylaxis at all. It may be what you're concerned about as well, which I have been for years, but there's no way you can tell. Okay? It'd be an interesting possible animal study to figure out how that would affect an animal if you can infuse it directly into the brain. Anyways, the medications, because they're water-soluble, will float in the water and the plasma. These agents tend to be very highly protein-bound. They tend to be very low protein-bound. So protein binding does not really tend to affect these medications so much. So if that person becomes nutritionally depleted and low on proteins, the medication is really not going to be altered by that effect. What's interesting about this is if you give ephedrine, because it goes to high blood flow areas, if you give ephedrine, which shunts the blood more to skeletal muscle, you will actually get a more rapid onset of action. Okay? And actually some people have recommended that in somebody who's hypotensive to give the ephedrine right before you give the muscle relaxant so it works faster. And it does. Okay? On the other hand, if you're in low cardiac output states, you can have a very prolonged onset time. In other words, there's a big delay in onset because the medication doesn't get to the skeletal muscle. Okay, so it has to get to the muscle to have this effect. Now, once it goes to the muscle site, okay, the medication, the way it actually terminates its action is due to redistribution many times. It has to come out of the neuromuscular junction where then it is terminated in action by metabolism. But redistribution is a big part of the actual job of this drug, to terminate its action. Plasma clearance is basically the actual volume distribution is small. It's only the extracellular space, so it does not penetrate into lipid tissue very well. It tends to stay pretty much only in the extracellular space. Things that can also affect the pharmacokinetics are things like age. As in men, have more muscle mass, so they tend to have a little bit more resistance to the agents in comparison to women. If you have somebody who's really muscular, it takes more to knock them down with the muscle relaxant in comparison to somebody who has small muscle mass. Volatile anesthetics also are very effective at suppressing the actual neuromuscular sites, not so much directly at the actual site itself, but it actually affects possibly the sodium channels on the axons. Plus, it may also affect the sodium-gated channels that the acetylcholine binding sites are at. Hepatic or renal diseases can also affect these agents, and you have to think about them depending on if they're being metabolized by those systems or not. Some drugs do not have that effect, like atracurium, but you still have to consider that in the back of your mind. Neuromuscular blockers, we already talked about that. The rate of disappearance in plasma is rapid. It's due to distribution, and there's eventual gradual decrease and that's due to metabolism of these drugs. Now, there's different kinds of descriptors of the actual clinical effects of neuromuscular blockers. You have your potency, your onset, duration of action, recovery index, and clinical duration. Your potency has to do with the effective dose necessary to depress a single twitch depression of 95%. That's the ED95. The lower that effective dose, the more potent the agent is. Okay? The onset, the time for injection to onset is the maximal single twitch depression, is important because you want to have someone with rapid onset. Okay? Because that way the drug works immediately, and that way you can be able to intubate successfully that individual. You don't want to have somebody that has delayed onset of action. Most of the non-depolarizing agents have delayed onset times of 3 to 5 minutes. The only exception to that is rocuronium. Succinylcholine, on the other hand, has a very rapid onset time of 1 to 1.5 minutes. So it's very rapid. Okay? Your duration of action will depend on a certain degree of how well binding sites are being bound by protein affinity. And the time to duration of action will usually run anywhere between 5 minutes for the depolarizers all the way up to 25 to 30 minutes for the non-depolarizers for the short-acting ones. The intermediate ones you're looking at 35 minutes, and the delayed ones, long-acting ones, are 45 minutes or greater. So you'll use them for different reasons. The recovery index is basically the time for 25% of single twitch height. Okay? And the clinical duration is the time of injection to recovery of train of 4 greater than 0.7. Really the value we want to reach now is 0.9. That's really where we now find it to be more safe. The initial thought that said you had 70% binding was okay. It's really not a good idea. So we really want to get up to much higher heights. Now let's talk about individual agents. Let's talk about succinylcholine. Now succinylcholine is actually 2 drugs in one. Okay? And you have to understand that. The book doesn't make that very clear. But this drug is basically 2 drugs. It depends on the dosage. Okay? If you go with low dosage, it binds only to the postsynaptic receptors. If you go to high dosage, it binds to not only the post, but also binds to the presynaptic junctions. Okay? And the effect is much more profound with high doses. Now, succinylcholine, people keep saying, oh, it's going away, it's going away, it's going away. Well, the major new drug that was supposed to get rid of succinylcholine was mivacurium. And mivacurium failed so badly that it's been taken off the market in 2006. So much for this drug going away. This drug is not likely to go away in the next 50 years, unless they find something brand new, which they haven't been able to find yet. So you're sort of stuck with an ugly duckling. It's got warts, it is ugly, it does have bad side effects, but it is one of the most wonderful drugs when used properly and keeps you safe. Now, what succinylcholine basically gives you the ability that no other drug does is that it has very rapid onset of action. So you can intubate somebody in about a minute, and you should be successful at intubating them with optimal conditions. Okay? No other agent does that. Okay? And the other beauty of it is, as long as you know the contraindications to it, it's actually pretty safe. Okay? And it has been used for almost 70 years now, or 60 years in practice. Now, the dosing that you give in the first low dose is a 0.5 to 1 milligram per kilo. The onset time is pretty fast, 30 to 60 seconds, which is 1 heart cycle. It gives you what's called a phase 1 block, and it causes, unfortunately, extensive fasciculations. After you give a low dose to somebody, they're not going to be happy with you. They're going to be myalgic. Now, there's reasons to give the low dose. I don't mind having a lot of pain after surgery with somebody if I knew the reason I went to the low dose was because I want to know that if I get into trouble and I can't intubate that person, that I can have that person breathing again in 5 minutes. So that's what the low dose does for me. The low dose, fast onset, fasciculates heavy, which tells me that the medication is working, and then I can be able to intubate. And this individual, if I can't intubate, I have 5 minutes before the muscle wears off. Pretty good. Nothing else is out there that can do that. Now, on the other hand, if I'm working in a day surgery center, and one of the things I cannot afford to have is somebody to have myalgias post-op, because it makes them very unhappy, because nobody in your actual outpatient center should be all be NPL. Nobody should be an aspiration risk or very low risk for aspiration. Then I'm going to use the high dose as long as I know I can ventilate. Okay, so what we do is we induce the patient, we grab the mask, we ventilate once. Once we know we can ventilate, we give high dose. And the reason we give the high dose, we give the 2 milligrams or plus, most of us will give up to 3 milligrams per kilo for high dose, is that the fasciculations are not even seen. The reason you're not seeing it is because this agent now acts as the second agent. It acts as a phase 2 blocker. It binds to the postsynaptic receptor, and it also binds to the prejunctional receptor, which doesn't allow any acetylcholine to be released. So this gives you a very, very profound block very quickly. The beauty of it is it'll last for 15 minutes. And you may have a surgical procedure that lasts 15 minutes. And you're happy because now the muscle relaxant's worn off, and the surgeon's happy because the patient never moved. Okay? Now, do people always recommend that? And the answer is, it's not really in the literature that much. There is several articles about it, but there's a lot of people that worry about that it may cause hyperkalemia. We've been doing this here for 7 years. Patients no longer have myalgias, and we don't have problems with hyperkalemia because you select the appropriate agents. Okay, so it can be done safely without too much of a problem. Okay? But you do have to understand that the onset of return to action is 10 to 15 minutes out. So if you can't intubate, you're in trouble. Okay? That's why you do one thing first. What do? Ventilate. Check if you can ventilate. If you can ventilate, you should be all right. Okay? Plus, and also in all the day surgery centers, we have glide scopes, which makes a big difference as well. You can see that this is the primary neurotransmitter, acetylcholine. Okay? Notice that it has a quaternary ammonium at the end. Okay? It's got a COOH group, which is a carboxylic acid group here. Now watch. That molecule looks just like succinylcholine. It's actually 2 acetylcholine molecules bound together. Okay? The way this drug works is that it takes the acetylcholine receptor sites, one side binds, the other side binds, and it's like strong arms that holds it in place and it won't come off. And that's how succinylcholine actually works. Okay? It has to act on the acetylcholine binding sites, and it depolarizes just like acetylcholine molecules do. So it mimics the action of acetylcholine. These are called depolarizing agents for that reason. Okay? They generate muscle action potential, and they're not metabolized by acetylcholinesterase. The way succinylcholine is broken down is by what's called plasma cholinesterases, also called plasma pseudocholinesterases. I don't know why they have the different names. It doesn't make sense to me, never has, never will. Okay? But they're basically the same enzyme. That enzyme is located in your bloodstream. And most people have it in very high amounts. Okay? The only people that tend not to have this in high amounts are Europeans. Okay? For some reason, Europeans have a higher predilection rate of having low levels of pseudocholinesterase. African Americans, Asians have very high levels of this agent. So it's very infrequently that you're going to run into trouble with this agent for what's called prolonged blockade in Asians and African Americans. You will have this problem in Europeans, though, because they have genetic variotypes. You have atypical pseudocholinesterase deficiency, which can be homozygous, which means that the 2 genes do not have any activity. So these people will be very, very prolonged effects, up to 8 hours with the actual dosing of succinylcholine. Versus if you're heterozygous, which means one of your genes has a production of pseudocholinesterase, then your actions can be prolonged up to 46 hours, so it can be a problem. Okay? Most people are normal, so usually don't have a problem, and the medication breaks down very quickly. Phase 1 block is it binds to the postsynaptic binding sites. It's after initial excitation, opening the sodium channels, the cytosolic side gate closes and the outer gate remains open. The action potential disappears and the membrane downstream returns to its resting state, resulting in muscle relaxation in a phase 1 block. The muscle cells will then repolarize and the channels cannot reopen until depolarizer detaches, allowing for the outer gate to close, which I already showed you before. Characteristics is you see a decrease in contraction in response to a single twitch stimulation, which I'll show you what I mean in a minute. And then we're going to go into it next hour in the hopefully next lecture. Decreases amplitude, but sustains a response to continuous stimulation. You get no fade, and you don't have any post-tetanic stimulation because you're not affecting the presynaptic sites, which I'll show you what that means. And we actually have animations for it, so hopefully make it a little bit more easy to understand. And also the augmentation neuromuscular blockade can occur after you use anticholinesterase inhibitors, which is something you don't want to use in these agents. So onset of phase 1 is accompanied by the presence of fasciculations because you're getting, it's a depolarization effect on the muscle. So if you look at this, the depolarizing block in phase 1, which is this box here, this is what you have to sort of memorize, okay, is that your normal twitch height, this is a normal, you get a reduction in your twitch height. But you see there's no fade. There's absolutely no fade. Every single twitch is the same height. Okay? If you look at double burst, which is a slightly different way of actually stimulating, you still see no fade. If you see the post-tetanic stimulation, there's no increase in your actual twitch height after you give a tetanus dose of electrical activity. So again, these agents basically bind to the postsynaptic receptor only, and they do not allow proper muscle activity. Now in phase 2, it's different. Phase 2 binds to both pre- and postsynaptic sites. And what it does is it begins to inhibit the release of the actual vacuoles. Now the way these postsynaptic sites are the presynaptic sites are bound is when the calcium opens. So when you get a calcium stimulation channel open, that's when the molecule binds inside of it and inhibits it. So in the first time you get a twitch, it's elevated, but the next one, because now the calcium won't allow it to be passed, you don't get the next vacuole release. So you get a diminution in vacuole release, and you get what's called fade as a consequence. So it begins to act more like a non-depolarizing neuromuscular blocking agent. And it does. Okay? And this effect can actually be partially reversed by the anticholinesterase agents, but it's not usually recommended because there's a lot of problems with doing that. So neuromuscular blockers, such as the non-depolarizers and succinylcholine-induced phase 2, are slightly different in the way their actions are, and I'll show you that a little later as well. Succinylcholine-induced phase 2 block occurs rapidly and occurs with higher doses. When you're giving the 2 to 4 milligrams per kilo, you're really going right into a phase 2 block. Okay? And repeated doses will do it, and continuous infusions. We actually used to do continuous infusion drips for succinylcholine. And it actually works still pretty well. And when we had a shortage of atracurium, I actually pulled it out and started showing people how to do it again. And everybody's like, oh, cool. Yeah, so you got to make sure that you're not going into phase 2, that's all. Now, you can also get what's called a mixed block. When you go into the in-between doses, you can start getting partially phase 1, phase 2. And the way you can actually, some people would recommend, is to reverse this effect by giving a little bit of edrophonium, which unfortunately edrophonium has been taken off the market recently, so you really don't have that ability anymore to do that. We're getting really shortage of a lot of anesthesia medications. But edrophonium is a shorter-acting reversal agent. The downside to it is that sometimes you'll overdo it, and you'll go back into cause the person to reparalyze. So it's not recommended to do this. It's best if you get into a phase 2 block, it's just stop the medication and give it time, and it'll wear off all by itself. That's really the best way to manage it. When you give succinylcholine, this is very important. When you give it into the person's bloodstream, the plasma cholinesterases, also known as pseudocholinesterases, break down 80% of the molecule. Okay? So when I'm giving a 4 milligram per kilo dose, only about 1 milligram is actually getting to the tissue. The rest of it is being broken down by the plasma cholinesterases. Okay? So you're basically giving a gross overdose every time you administer this drug. Now, there's a real problem with that, because if the enzyme's missing, that gross overdose is not going to go anywhere. It's going to still circulate in your body and eventually gets rid of very, very slowly, but it just takes a long time. Okay? So when you have plasma pseudocholinesterase problems, that's when you can actually see the muscle stays paralyzed. You can see this in people who have liver disease, but it usually has to be very, very severe liver disease for it. Or you can have the genetic variotype where you just don't have the activity to produce the plasma cholinesterase molecule. You can see where it cleaves the succinylcholine. It cleaves it right at the carboxylic acid group and breaks it down into choline for you. The duration of action and you got to ask yourself, why would you have this? Why would you have an enzyme in your system that would be able to break this stuff down? Because when you eat a bunch of plants, okay, you have a lot of acetylcholine-like molecules in plants. And if it gets absorbed into your bloodstream, it can really mess you up, okay, if it had activity. So in this case, you have plasma cholinesterases. Those get broken down, and it doesn't affect your neurotransmission. And that's why you can see some people that eat certain foods, they start getting erratic, and they start acting weird. And those people are actually, they're not psychotic. They're responding to the food that they're eating, while nobody else is having that problem because none of the other people have plasma cholinesterase deficiencies. That individual has a plasma cholinesterase deficiency, can't break the molecule down, and it's beginning to affect their neurotransmission, and they get twitchy, and they look strange, and they just can't seem to stop moving. And it's from the excess amount of choline that's being absorbed in their GI tract. Pretty interesting stuff. Okay? So thank goodness most of us have high enough plasma cholinesterase levels where that's not really an issue. All right, I'm going to start back up. I'm going to have to try to pick up the pace. I'm going a little too slow. A lot of slides. Yeah. All right, so let's go back to succinylcholine. Okay. Succinylcholine, normally when you give the low dose, you're going to have a brief duration of action, about 3 to 5 minutes. Most of it's due to the hydrolysis by the plasma cholinesterase enzymes, which we showed you before. It seems like significant amounts of succinylcholine are circulating after 3 minutes after injection of the dose. So it's ultimately the plasma cholinesterase that are important for breaking this stuff down. If you don't have it in high enough concentrations in the bloodstream, you will get accumulation and you'll get reblocking taking place. One of the things that's unfortunate is that at the neuromuscular junction site, there's no plasma cholinesterases. And there's no, the acetylcholinesterase that's there does not break down succinylcholine at all. It won't touch it. Okay? So you really are dependent on diffusion away from the neuromuscular junction site for the termination of action by breaking down the molecule, ultimately by the plasma cholinesterases. If you don't have any way to redistribute because the plasma concentration stays high, because you don't have any plasma pseudocholinesterases to break down the succinylcholine, then the medication just redistributes out in the plasma and goes right back in and causes the effect again. So that person stays basically muscle relaxed for long periods of time. Now, if you have decreases in plasma cholinesterase activity, it can be due to decreases in hepatic production. This usually is not seen until you have very, very severe disease. Okay? You can see also things that will cause it by drugs. Drugs can actually affect plasma cholinesterases. And also there's genetic differences that you'll see, which we'll talk about, which are the atypical cholinesterases. And the population that you see this in is usually in the European population. You tend to see this very rarely in Asiatics and African Americans. Now, the drugs that decrease plasma cholinesterase activity are things like neostigmine. So neostigmine itself has direct effects on plasma cholinesterase and actually inhibits it, which can potentiate the effects of succinylcholine if you're using this agent with it. Okay? So it's one of those things that if you give, this is very, people make this mistake. Somebody is muscle relaxed, okay? And at the end of the case, you think you're finished, you give reversal. And then after you're finished with reversal, the surgeon says, I've got to go back in again. What do you do? At that point, you already basically crossed the bridge and you're not going to be able to cross it again. So what you do is turn on your volatile anesthetic, deepen them with that, and hope that'll hold it, okay? Because if you try to use another agent, another non-depolarizing agent, you can have a very prolonged effect, okay, or it may not work at all. Or if you use succinylcholine, which I've seen people do, then all of a sudden succinylcholine doesn't work for 5 minutes. They work for 45, 50 minutes. And the reason being is you gave reversal. You gave the neostigmine. Okay, so that binds to the plasma cholinesterase, and now instead of having a 5-minute drug, you got a drug that's going to work 45 minutes to an hour. Okay, so be very, very careful about that. The other thing that will also cause decrease in plasma cholinesterases are things like insecticides. It's actually one of the leading causes of death in rural areas in the world, is that people use insecticides to inhale it, and bad things happen as a consequence. Then you have glaucoma drugs that are present in your patient's population, which is in the elderly is pretty common. Chemotherapy drugs like cyclophosphamide and nitrogen mustards are also affect the plasma cholinesterase activity. When we used to use metoclopramide, it used to have a lot of inhibition of plasma cholinesterase activity. We tend not to use metoclopramide very much anymore, so it's one of the things also to be worried about. And women that are on high estrogen levels, or which are the oral contraceptives, can also have a decrease in plasma cholinesterase activity. The other thing that will decrease the activity of the actual enzyme, because temperature fluctuations will cause denaturation of the enzymes, will be hypothermia. It also decreases the plasma cholinesterase activity, and succinylcholine will have long-term actions as a consequence. The other thing that you have is you have genetic variances, which are called the atypical plasma cholinesterases. If you have this, you have a prolongation of block, and you usually don't find out until you give the person that drug. There's really no clinical symptoms that these people will have, unless you really ask them specifically, do you have any kind of weird reactions to certain foods? And they tell you, yes, I sort of get jittery when I drink some things. Then you'll sort of pick up that maybe they're atypical in their pseudocholinesterase. But you have to have a real high clinical acumen to pick something like that up. Most of the time you just pick it up when you give the succinylcholine, and then you find out that they have no twitches. That's why before you ever give a non-depolarizer following your succinylcholine, you should always check your twitch. Always. Every time. Never forget that. I've seen people get, oh, well, the person's been 10 minutes, I'm going to give the reverse, I'm going to give the muscle relaxant now because the succinylcholine's already worn off. They assumed. You know what assume means, right? It makes an ass out of me and you. Okay, so don't do that. Okay? So, you and me, sorry. So please don't do that kind. Never assume anything. Check with your monitor, make sure that you have muscle twitches back, so that way you know they're not pseudocholinesterase deficient. Now, one of the things that we can actually pick this up on is by using what's called dibucane. The dibucane is a local anesthetic that will normally inhibit the activity of normal pseudocholinesterase. It has minimal activity on the actual atypical pseudocholinesterases. And then they do assay values to find out how much the value of that molecule is. If you have somebody with a normal value, you'll get what's called 80% inhibition of plasma pseudocholinesterase. Okay, so what they do is they take this person's they take this person's blood, and then they drop dibucane in it, and you should see a normal 80% inhibition of the activity. Okay, if you have heterozygous, okay, which is 1 in 50 patients will have this problem, you'll see that their activity is anywhere between 50 to 70%, and they have a prolongation of block for about 20 to 30 minutes. And it's because they have one normal gene, so you still have adequate numbers of pseudocholinesterase, but just the action of the drug is going to be prolonged. If you're, on the other hand, you're homozygous, which is about 1 in 3,200 people, it results in a very long blockade of anywhere between 6 to 8 hours when you have this being present. When you look at your dibutane number, it doesn't really affect the inhibition of activity, so the number you get is usually around 20%. Now, if you do have somebody with plasmacholinesterase deficiency, you can actually try to reverse it, and it will work if you give the person FFP. We don't really condone that kind of practice because FFP can actually carry bloodborne infections, so it's something that you can just wait it out. If you wait it out, it will break down. So the most recommended treatment is just mechanically ventilate that individual, put them in the ICU, sedate them, make sure you don't forget to sedate them, and usually you'll get return of activity between 8 to 12 hours later, and the person can then be safely extubated and everything's fine. And then you just got to tell them you have pseudocholinesterase deficiency and tell that to the next doctor that takes care of you, okay, so they don't have that problem again. You can still, if I had somebody with pseudocholinesterase deficiency and I knew that they were going to be a trauma patient, that they had to be rapid sequence because they're full stomach, is it going to stop me from giving succinylcholine? Absolutely not. I'm going to still give it, okay, because I want that rapid onset to get them intubated quickly. Okay, I just may reduce my dosage a little bit. I still know that it's going to work for a long time, but I will actually pay the price sometimes to get something that we need at that time. The other thing you can do is you can administer cholinesterase inhibitors. That's very controversial. I actually don't think it's a really good idea because sometimes neostigmine can actually intensify the block because it inhibits more of the pseudocholinesterase, so it's really not a good choice. Edrophonium, on the other hand, can be used, but it's been pulled off the market, so now you can possibly find it in some hospitals, but they're just stockpiled for now, so there's not many of it left. Resistance to succinylcholine can occur from increase in plasmacholinesterase activity. This can be inherited or acquired. Okay? People that are morbidly obese tend to be a little bit more resistant to succinylcholine because their volume distribution goes up a little bit. The myasthenia gravis patients also have a resistance because they don't have enough receptors to bind them to. Okay? So somebody who's myasthenic is very sensitive to the non-depolarizers, but is exquisitely resistant to the depolarizers. Okay? The depolarizers just don't work. There's not enough receptors to cause depolarization of the muscle and cause the activity. And the other thing you'll also see in some people with have tremendous fibrosis of these actual membranes, and it basically decreases the receptor count, will be juvenile hyaline fibromatosis. Adverse side effects is many with succinylcholine, and this is why everybody's been trying to say that succinylcholine is going to go to the wayside. And my answer to that is, well, there's so many good things about the drug that these things are considerations and always thoughts in the back of my mind, but it's not going to really prevent me from using it if I exclude all these possibilities. The first one I want to exclude is I don't want to induce a malignant cardiac arrhythmia, which is usually due to a hyperkalemic response. Okay, so hyperkalemic response should go with cardiac arrhythmias together. It causes a hyperkalemic cardiac arrest. If you go to low doses, you'll tend to get more myalgias, and if you cause too much fasciculations, you actually will cause shearing effect of the muscle, and you actually will get myoglobinuria. If you already have partial damage of like crush injuries and you give succinylcholine, you may actually go into rhabdo. So it's one of the things to be considering. It increases intragastric pressure, increases ICP. The ICP increase is not considerable enough to contraindicate its use. Increase in intragastric pressure, I'll show you in a minute. It may be a problem, but the benefit of rapidly intubating somebody is faster. It may be more important and outweighs that risk. And you may also get sustained muscle contractions, which will make it difficult to open the mouth. And also you may see these people may be activated to develop malignant hypothermia. So that's a big concern. The malignant hypothermia risks are more in the Europeans. We tend not to see it in other populations. Not to say that you shouldn't worry about it. It's just that the genetics on it most of the time is due to Europeans, mostly Scandinavians in origin, to develop MH. Cardiac dysrhythmias, the most likely secondary dose it can cause your problems. The first dose never causes bradycardia. The second dose, if you wait 30 seconds after you've given the first dose and you give it another dose of succinylcholine, you will now selectively bind the parasympathetic side of it. So now you'll bind to muscarinic acetylcholine receptors, and you'll get a very profound bradycardia and asystole. So you cannot give a secondary dose of succinylcholine. You give one whopping dose, and that's all you get. So you got to decide, low dose, intermediate dose, or high dose. Decide what you want, but don't give low dose and followed by another low dose. If you do that, you're going to get burned. You can get severe bradycardia, maybe even asystole, or sinus arrest. Okay? Atropine doesn't seem to prevent the bradycardia on the second response, so that's also not a good thing, because you can't reverse it, its action. Succinylcholine's action on the autonomic nervous system ganglia may produce ganglionic stimulation, which results in an increase in heart rate and blood pressure, usually on the first dose, but not on the secondary dose. Now, hyperkalemia is most of the time is induced by diseases that deafferent or have problems with the muscle itself. So people with muscular diseases, you need to be very careful with succinylcholine. People that have any kind of nerve injury, stroke, spinal cord injury, alpha motor neuron disease, Guillain-Barré, all those people have a high risk of developing the extrajunctional receptors, which causes neonatal receptor activity on the muscle, which can cause a hyperkalemic cardiac arrest. So you need to avoid, for those reasons, succinylcholine in these patients. If you have somebody who comes in with a burn, especially second and third degree burns, mostly third degree burns are your biggest risk, causes deep tissue damage. And most people don't understand that. You can actually get axonal damage by heat at the skin level. And so it causes deafferentation, the muscle as a consequence, and you get the neonatal receptors to upregulate. Usually it's seen between 24 hours after the burns. So if somebody comes in with active burns and they're still, you can see that the burns just happened just about 10 minutes ago or 20 minutes ago, or even within the first 24 hours, and you're asked to intubate that person, it is still totally safe to give succinylcholine to that patient. Okay? You have a 24-hour window, because that 24-hour window is before the neonatal receptors then upregulate. Once they upregulate, then you can't use the medication. And you don't know how long that upregulation can take place. There's things called burnout that happens over time, which is somebody who has a stroke, is it safe to use succinylcholine? And the answer is maybe, but are you going to take the chance? You may have to sometimes because somebody's really sick and you may have no other choice. But the way you do it is you make it a clinical judgment by looking at the muscle. If the muscle is still large and present, then that person will cause hyperkalemic cardiac arrest. If the muscle is significantly atrophied and you see that person's arm is 1/10 the size of the other arm, then that person won't do anything. That's called burnout. That muscle has burnt out itself down to its complete atrophy. All you're left with now is just basically ligaments. And when you give that person, nothing happens. There's no muscle mass. Okay? And I've done that before. And, they say strokes are not contraindication. Yes, but this guy had all sorts of other problems, and had a stroke 10 years ago, and his muscle had atrophied to the degree, but it should be safe, and it is safe. But you usually have to wait 4 to 5 years. It takes a long time for that full atrophy to take place. And you've got to be really careful. If there's other choices, take the other choice if you can. Prolonged immobility will also cause this. I've always wondered what would happen if you give this to astronauts in space. I'm just wondering if you get a severe hyperkalemic arrest in that situation. But the normal increase of potassium when you give succinylcholine is 0.4 milliequivalents per liter. That's not bad. So if you start at 3.4, you're up to 3.8. You cured the hypokalemia. Cool job, But if you're at 4.5 or 5.8, and then you give it to somebody who's got burns, the actual rise could be as much as 1 to 2 to 3 milliequivalents per liter. So in other words, you go from 4 to 7, like that. And the heart will not appreciate that very much, and may arrest on you. Okay? You will pick up when somebody's having a hyperkalemic arrest because you get a peak T wave followed by prolongation of QRS with eventually a sinusoidal wave pattern and asystole. The way you're treating it, of course, we discussed it before. Just don't panic. Begin to hyperventilate. Continue doing CPR. Give calcium as memory stabilizer. Give sodium bicarb, and follow it with insulin and glucose. And if you do that, within 5 minutes, usually the potassium will reverse back into the cell, and everything will be fine. It's just that you'll look like a little bit foolish because you sort of forgot about the risk of using succinylcholine, but at least you won't have a dead patient. Okay? I've seen 3 people do this in my career. All of them were residents that sort of forgot this lecture, and they found out the hard way. The good thing is we got all 3 patients back, and there was no really bad effects on those people. One time they gave it to a patient who was a spinal cord patient in the unit, and that guy arrested on the spot. He went full asystole, but we got him back. Like I said. Now, myalgias may be a big issue, and it's usually because you're only using the phase 1 blockade, which is a low dose. Occurs more often in skeletal muscle, the head, neck, back, and abdomen. And it can make really people very, very uncomfortable, especially in young adults, which are more muscular, and sometimes can be perceived as sore throat. Some people feel that it can be partially reversed by giving a pre-dosing of non-paralyzing, non-depolarizing agent. The danger of that is you may actually paralyze the individual before you actually have the effect, and you have to give it at least 3 minutes ahead of time. So you're running the risk of somebody already being partially relaxed before you want them to be even induced. So I'm not a real fan of this. Instead, I give high dose. That's what I've gone to in the last few years. If I want to have somebody with no problems, and I usually give 2 to 3 milligrams per kilo, and gives you a much better, it's really ideal for intubating because you get profound muscle relaxation, and it lasts for anywhere between 10 to 15 minutes. Now, this is what will happen if you get myoglobinuria. You get damage to skeletal muscle. You'll see the urine will begin to change on you. It'll go from the yellow and eventually go into this very dark looking stuff that looks like beer. This is your actual myoglobin in your muscle that's coming out of it. Not good. And if you're not careful, you can induce renal failure with that. So it's something that hopefully we don't see very often. I keep looking for this all the time every time I give succinylcholine, and I've never really seen it just yet. I've heard about it usually in trauma patients, but usually in trauma patients that are over 24 hours. And it could be from the crush injury from the accident as well, not really associated with succinylcholine. You can get sustained muscle contraction. This can be used to be seen a lot more when we used to use halothane as an induction, followed by succinylcholine. And it may be a problem because you then can't intubate because you can't open up the jaw. The other thing, too, is it's associated with MH. So if you see that in a child, you've got to really have a high incidence of suspicion that you may actually have an MH kid in your hands. Okay? The only 2 MH cases I've ever seen in my life were 2 kids. I had them back-to-back within 2 weeks. Talk about fun. Dantrolene is definitely a life-saving drug, but it's nothing but a scary situation to be in. Now, if you have intragastric pressure, it occurs because the skeletal muscle, in this case the abdominal muscles, contract during a low-dose induction dose of succinylcholine. If you tend to give the higher dose, you tend not to get this problem, but with a lower dose, you tend to have this. It may increase the risk of aspiration because it allows for the stomach to actually contract and be pushing up its material up. I've seen this to be really infrequent, and you use cricoid pressure to basically prevent passive aspiration to take place. So hopefully you won't have that problem. As for increased intraocular pressure, this has been something that's really been overplayed way too much in the literature, and it's caused people to stop using this drug when you should be using it. Okay? The problem with intraocular pressures is that what causes more of an increase in intraocular pressure? And the answer is coughing. Coughing is really very, very bad. If you're intubating somebody and you cough, the eye will totally extrude out and come out, and the case is over. The person will be blind at that point. Okay? So if I do this, if I plan to do a rapid sequence induction, because almost all these people are full stomachs, then I use high dose. I go to high dose and get them intubated quickly. And they are so muscle paralyzed that they never move, never cough. And yes, does the intraocular pressure go up a little bit? Yes, but not any more than if you ever put the laryngoscope in somebody's mouth. Okay, so that's going to cause an increase in intraocular pressure because you're going to drive the blood pressure up when you do that. So there's different techniques that can help reduce intraocular pressure by giving the person more narcotics up front, and so you don't get the sympathetic stimulation as much. But really to avoid succinylcholine because you think it's going to extrude the global contents, it never made any sense to me, so I sort of watched my other friends do inductions with rocuronium and mivacurium, and it was a disaster 2 or 3 times that I saw it done. In both cases, the muscle relaxant had not kicked in, and when they put in the blade in, and the person started coughing, and the game was over. So that is much more of a serious problem. If you are going to use a non-depolarizer because you believe that it's more dangerous to use succinylcholine, then my answer to that is you make sure that the person has no twitches when you're intubating. So you've got to put your nerve stimulator to their skin and make sure you have nothing in response. Okay? To make absolutely sure that you're not going to have that. But of course, now you're going to be waiting quite a long time because it takes 3 to 5 minutes for the non-depolarizers to work. What's happened to your stats at this point? They're beginning to fall, so you're beginning to freak out, and now you're under pressure to get this person intubated within a minute. Not easy. Okay? So, give yourself some time so you can intubate somebody safely and just go with a good dose of succinylcholine. I think that's a better way to go. Increases in ICP can occur, but never been a contraindication, so I'll keep moving along. It's really not a significant problem. Reversal, for the depolarizing agents, is basically they're metabolized by the plasma cholinesterases. That's the way, not by acetylcholinesterases. So the only time this would actually work is if you're in phase 2 blockade, which again, it's really the best thing to do is just wait it out. Okay? With the exception of mivacurium, non-depolarizing agents are not metabolized by their acetylcholinesterase or pseudocholinesterase. In the non-depolarizing agents, the reversal depends on redistribution, gradual metabolism, excretion, and administration of reversal agents, which we'll talk about in next week's lecture. The non-depolarizing neuromuscular blockers is the next thing we're going to talk about. They can be classified clinically as long, intermediate, or short-acting. The short-acting one has gone out of the market, which is mivacurium. So what we're left with is intermediate or long-acting agents. The decision as to what you should use depends on the onset time, duration of action, rate of recovery. Metabolism in certain disease states will make a difference between which drug you're using, clearance, and cost. The clinical classification is that these are all quaternium ammonium compounds. Okay? If you look at all of them, they all have quaternium ammoniums in them, okay? Which is here, here. Okay? Tubercularity also has the same thing. The families can be broken down into two major families, which is the benzoisoquinolones, or quinoliniums, okay, which has a quinoline group in it. The way you know which one is a benzoisoquinolone is they all have acurium in it. Okay? A-C-U-R-I-U-M in their wording, except for curare. Curare is the only exception because that was the initial drug that came out. Now, the way you know that curare is a benzoisoquinolone is that it also releases histamine. All the benzoisoquinolones tend to produce some degree of histamine release, depending on how much you use. Okay? The aminosteroidals, on the other hand, are steroid-based molecules. You can see how their actual steroidal structure, which is like anything else that has steroid structure, like cholesterol, and it's a major steroid structure. And the actual wording inside of it is curonium. So it's C-U-R-O-N-I-U-M. So curonium. Anything that has curonium in it is basically aminosteroidal. So you have the major ones that we're going to talk about is pancuronium, vecuronium, pipocuronium, and rocuronium. Okay? Pipocuronium I'm going to throw out. You won't have to worry about that in the test. Pipocuronium is a very long-acting muscle relaxant that's almost never found anymore. It's really not useful because it's too long-acting, and it has none of the benefits of Pavulon. So we tend to have replaced pipocuronium completely and not really using it anymore clinically. Doxycurium, which is also a long-acting benzoisoquinolone, is also not used very extensively in this country. Maybe used in Europe, but not really used in the United States. Now, the non-depolarizing agents, they work differently than the depolarizers. They actually block and act as antagonists. So non-depolarizing agents are competitive antagonists. Make sure you know that. One is an agonist, the other one is an antagonist. Okay? They bind to the acetylcholine receptors but are unable to induce a conformational change for the ion channel to open. So they act as competitive antagonists. The mechanism of action is because they're competing, they bind to the alpha subunits at the post-junctional receptor sites. Their occupation, as many as 70% of the nicotinic receptors, does not produce evidence of blockade. That's pretty impressive. That means if you have a train of 4, okay, which means that you have a twitch height of train of 4, and you think everything's fine, that person's 70% blocked still. So can you really tell me that your person is perfectly safe to wake up and extubate at that point? And the answer is no. So clinically, we have a very hard time telling with just our monitors when somebody's adequately reversed. If you have neuromuscular blockade, it occurs up when 80 to 90% of the receptors are blocked. Also, it acts on the pre-junctional nicotinic receptor sites, which I'll show you that in the next lecture series. The characteristics is they have a decreased twitch response to a single stimulus, which is the same thing you would get with a succinylcholine. What makes it different is that you get unsustained response or fade during continuous stimulation. Okay, the fade effect is because it binds to the presynaptic site. It's acting more like a phase 2. So what it's doing is it's preventing the vacuoles to being released every time you stimulate. Okay, and the way these agents work is they wait for the calcium channels to open for them to bind into the site. That's why when you do a train of 4, the first twitch height is high, and the next one gets lower and lower and lower. Okay, and I'll show you pictures and animations of that, hopefully, when we get to it. You see a train of 4 ratio of less than 0.7. You do get post-tetanic potentiation. You get potentiation of other non-depolarizing drugs, so you don't want to mix relaxants. That's really not a good idea. There's never been a good study done where you had 2 muscle relaxants added together. Sometimes you get synergistic action, things like galamine and D2-bucurari, when mixed together, gives you an 8 to 12 hour paralysis. Very bad combo. So you don't know what's going to happen, so I don't recommend you switching agents. Stick to one at a time. You have antagonism by anticholinesterase agents because they can compete. When you give the anticholinesterase agents, you basically increase the acetylcholine levels high enough that now acetylcholine can competitively push off the non-depolarizing agent, and you can get the resumption of action. The absence of fasciculations is evident because you don't get any depolarization effects, so you're not opening the sodium channels in this kind of drug. And none of these drugs really cause malignant hyperthermia. Okay? So that's a good thing. So non-depolarizers don't cause MH. What you see here is non-depolarizing agents in the second column. You see the fade effect with either the train of 4 or double burst. And you can see when you do post-tetanic stimulation, you'll see that the tetanus begins to drop off right away, and you see the post-tetanic train of 4 that is accentuated initially, but then rapidly diminishes. Now, the cardiovascular effects of these agents depends on which agent you use. If you're using the benzoisoquinolones, they tend to affect the heart by causing histamine release, so you get a preload reduction, and you get a drop in cardiac output as a consequence. As for the other agents, such as the aminosteroidals, they tend to be more cardiovascular stable. The only exception, of course, is Pavilon, which can also affect muscarinic sites and can also affect the nicotinic sites in the autonomic ganglia. There's what's called autonomic margin of safety. Is the difference between the dose of neuromuscular that produces neuromuscular blockade and circulatory effects. The safety for pancuronium is narrow compared to vecuronium. Vecuronium is actually a very, very stable agent cardiovascularly, and that's why it's really used. But if you want something to increase heart rate activity, you give Pavilon. Pavilon does increase heart rate dramatically. Now, one of the bad things about giving people non-depolarizing agents for long periods of time in the critical care area is that you can have prolonged paralysis and it can be permanent. Okay, so it can be very, very severe, and it's been associated with giving aminosteroidals with steroids. So if you're giving somebody steroids, you really need to rethink having to give the aminosteroidals. Instead, you may want to consider giving that person more of the benzoisoquinolones and accept the histamine risk. So one of the things that you need to be, another thing to be concerned about. No drug is perfect, okay, and that's what I'm sort of wanting to make sure you understand. Drugs that enhance the neuromuscular blockers are the volatile agents. Antibiotics, especially like the aminoglycosides, tend to have an effect. The good thing is that most of your cephalosporins and penicillins don't have any effect on muscle, except for the only exception to the rule is piperacillin. Piperacillin can have an effect on muscle relaxation. Calcium channel blockers, which is the way the aminoglycosides basically inhibit. They inhibit calcium channels. They enhance the neuromuscular blockers. Same thing when you give the calcium channel blockers, it acts the same direction and causes problems. Local anesthetics, which are sodium channel blockers like lidocaine, can also enhance the effects of neuromuscular blockers. And things like cardiac antiarrhythmic agents like procainamide and quinidine can also cause problems. These are the ones you also will see, which we'll get into in a second. The volatile anesthetics that produce a dose-dependent increase in neuromuscular blockade, and that's really important for you to understand. If you take a person and you're inducing them, and you take your train of 4, and you see that their train of 4 is slightly diminished because you gave a little bit of atracurium, when you turn on that volatile agent, the train of 4 will actually disappear. So it really potentiates the effect. And that's good to know because sometimes you're giving a muscle relaxant and you don't need to give as much as you might think. It's always better to give a little bit and wait it out and see what the effect is than to give a big dose and then be going like, geez, I wish I had given less. Because now you got the surgeon's almost done and you got no twitch. That's a bad place to be. Okay? It's really greatest with isoflurane, desflurane, sevoflurane, and you have intermediate action with halothane, but halothane still has pretty potent effects. It's least with nitrous opioid combinations because nitrous does not really affect sodium channels, so you don't really have an effect at all. It doesn't cause any real degree of muscle relaxation with nitrous. The magnitude of dose requirements is least with the intermediate acting agents, okay, and the effects are most likely due to anesthetic-induced depression of the central nervous system, okay, which we talked about before. Antibiotics are prominent with glycosides. Okay, they antagonize the anticholinesterase inhibitors, and calcium is kind of unpredictable. Sometimes you'll see very profound effects on some patients, and other ones you don't. Antibiotics can also, without this effect, include the penicillin and cephalosporin, with the exception being piperacillin, which I said before. Local anesthetics, they enhance it by causing the sodium channels to be blocked. Large doses of local anesthetic block neural transmission, which of course is going to make the muscle weak already. You'll get local anesthetic blocks prejunctional releases of acetylcholine as well, and directly depress skeletal muscle fibers as well. You use ester local anesthetics, competes with other drugs for plasma anticholinesterases, thus potentiating succinylcholine, which is also a concern. That's something we tend not to use esters in the operating room. Remember, we tend to use amines. Cardiac antiarrhythmic agents, IV lidocaine via sodium channels can actually have a potentiated effect. Quinidine produces the effect via calcium channel inhibition at the prejunctional release of acetylcholine. Diuretics such as Lasix or furosemide enhances neuromuscular blockade. The actual understanding of that is mostly due to loss of potassium. Mannitol, on the other hand, does not affect the degree of neuromuscular blockade. And chronic hypokalemia due to diuretics, it decreases dose requirements for Pavilon and increases the dose of neostigmine needed to antagonize the block. Something to be considering in the back of your mind. Magnesium is another thing that will enhance neuromuscular blockade. If you give enough magnesium, it will membrane stabilize the person to the point that they'll lose their deep tendon reflexes, and it'll make the person profoundly muscle relaxed. Unfortunately, the person's still awake, so that's one thing you got to be careful with as well. It's, you see this effect very pronounced when you give vecuronium, so be very careful about using vecuronium in the operating room, in the postpartum period, in the obstetrical patients, because a lot of them, they have magnesium already on board, and you can have a very prolonged vecuronium effect. The ganglionic blockers, which we don't use very often because they cause pupillary dilation, which is they cause mydriasis, is trimethoprim. Trimethoprim does several things. It's a ganglionic blocker, so it basically decreases skeletal muscle blood flow, which causes a delay of onset of action, and also may basically shunt the blood to other areas. It also tends to inhibit plasma cholinesterase activities, which can enhance the effects of the muscle relaxation. And it decreases the sensitivity of the post-junctional receptors as well. Phenytoin, also known as Dilantin, is usually, it depends on how you're treating it. If you're using an acute setting, there's no upregulation of the receptors at that point, so you don't have any problem with it. Actually, it may actually sensitize that individual. But if you have somebody with high doses of phenytoin for a while, that's caused an upregulation of receptors, which makes it more difficult to block with a non-depolarizing agent. The depolarizing agents actually work faster when you give phenytoin to them. Okay, yes? Most of the time we're talking about non-depolarizers. We now moved on to the non-depolarizer area. Okay? Yeah, we talked about that before. There was another section before that talked about succinylcholine medications. Okay, but it's unfortunately, this is the way I've separated out into depolarizing agents, one side, which is what we talked about initially. Now we're talking about the non-depolarizing agents. I'm trying not to talk back and forth between the drugs because there's some drugs that also affect the non-depolarizers and also affect the depolarizers. Okay, but I'm trying to keep that separate for you. This is only about non-depolarizers. So right now, this discussion is on non-depolarizers. This is a general description of what happens with all the non-depolarizers. Then we'll go into the specifics about each drug. Clinical causes of altered response is that hypotension can shunt blood away from skeletal muscle. Okay, so hypotension can actually cause a very delayed effect to take place when you're giving non-depolarizers. You tend to, if you're using a depolarizing agent, you tend to see this effect very little because it's so rapid in onset. Okay, but the non-depolarizers, it's really evident because it takes such a long time for these medications to already work. To actually take them even longer, it's really pretty painful. If you give somebody Esmol up front and you give them a non-depolarizer, you can actually see a very delayed onset time before the medication kicks in. You can also see alterations in acid-base status, potassium, adrenocortical dysfunction, thermal injuries, allergic reactions, and gender. All these affect your non-depolarizing agents to different altered responses. So let's take a look at each individual one. If you look at serum potassium levels, okay, this is where, unfortunately, I had to give both in this drug. In hypokalemia, you get an increase in transmembrane potential causing a hyperpolarization. And in these individuals, hypokalemic patients tend to be resistant to succinylcholine, but they have a tremendously increased sensitivity to non-depolarizing drugs. As for the hyperkalemic patients, on the other hand, you have a decrease in respiratory membrane potential, which increases sensitivity to succinylcholine and increases resistance to non-depolarizing agents. Okay. If you have somebody with burns, what happens over time is you get an increase in the actual neonatal receptors all over the muscle. So when you give this individual, it soaks up the muscle relaxant without really good activity. So you need to give a very high dose of a non-depolarizer to a patient who's got burns. It is contraindicated to give a patient with burns acetylcholine, succinylcholine, because you'll kill them. So we're only talking about the non-depolarizers in this effect. The timeline that you see this is very profound after about 10 days after injury. You're literally having to double, almost triple the dose of the actual non-depolarizers to get the effect that you want. And it can last up to 60 days, and usually then begins to decline after that. Hypothermia prolongs the action and the duration of neuromuscular blockade because simply you're moving the molecules at a slower rate. Remember, the molecules have to come off the receptor for them to terminate their action. So if you slow down that molecular speed by making the person cold, then you get less diffusion movement, and as a consequence, you get a prolongation of effect. So hypothermia prolongs the effects of almost all the neuromuscular blockers. If you have somebody with paresis or hemiplegia, okay, that person, it depends on where you're monitoring. If you're monitoring the side of the hemiplegia, that area is already burnt out. So when you do the twitch monitoring, you're not going to see the effect that you want. So you tend to believe that the person is adequately muscle relaxed. There's also upregulation of these neonatal receptors, which also will soak up this side, and you won't see the effect that you want to see. So it appears to have decreased sensitivity to the neuromuscular blockers. On the other hand, the unaffected side, the other side that is damaged, is soaking up the neuromuscular blockers, so you're not getting the effect that you want on the side that is normal. So that person appears to be unaffected, shows resistance to the effects of neuromuscular blockers. Okay? And so monitoring these people can actually become a real problem. You don't really know where you're at. And that's one of the issues that you may have with these individuals. Allergic reactions are rare with most of the neuromuscular blockers. They can occur, though, and they're usually associated more with the benzoisoquinolones, which tend to release the actual histamine more so than the immunosteroidals. So the ones that have a single quaternary, which is called a monoquaternary ammonium group, which I'll show you a picture of that in a minute, which are things like rocuronium and becuronium, tend to be less allergic than people with the bis or more, which means two ammonium groups, which is the other drugs. Succinylcholine followed by non-depolarizing neuromuscular blockers can actually enhance the effects even after the effects of succinylcholine have waned. So that's something you have to be aware of. Always check your train of 4 before going into the next agent. Okay? And succinylcholine seems to desensitize the post-junctional membranes, leading to an enhancement of the non-depolarizing agents. So what I would do is if I use succinylcholine up front, and then I plan to use a non-depolarizing agent, I go with a lower dose than I think is necessary, and then I watch what happens. A lot of times I'm actually pleasantly surprised that it's actually worked just fine. Now, if combinations of neuromuscular blocking agents really shouldn't be done, you can have very synergistic actions, things like Pavilon and metacurine. The other one was galamine, and D-tuberculari can also be very, very detrimental. Those work for 8 to 12 hours. VEC and D-tuberculari is also one that has very significant synergistic action as well. Not as prolonged. Usually, instead of working for 45 minutes, which is what VEC should work, when you add it with D-tubo, you can get an effect of up to an hour and a half to 2 hours. Gender. Men tend to have less sensitivity to muscle relaxation, and they need more dosing because they have more muscle mass normally. If a woman is working out a lot and she's very muscular, then she will become more resistant to these agents. Okay? So one of the things that you may see is that women tend to be more profoundly blockaded for the same dose, and as a consequence, they have more problems with recall during the case. Because they are redistributing their medications fast as well, but they don't do that with the muscle relaxants because we're giving a more of a dose to them than they really require for their body weight. Okay, pharmacokinetics and pharmacodynamics. Quaternary ammonium compounds are all the neuromuscular blockers. They're all highly ionized. They're all low lipid solubility agents. Their volume distribution is basically the same as the extracellular fluid volume. There's no CNS effects, which I talked about before. There's minimal tubular reabsorption. They're not really absorbed orally, and they will not affect inhaled anesthetics, their action, but inhaled anesthetic agents will affect neuromuscular blockers, okay? Which means that one agent passes into the brain, the other one does not, and affects both, which is what the volatiles do. Now let's go into the aminosteroidals. That's the first family group. The reason I picked this one is because it's the more stable compounds. These are much safer than all the other benzoisoquinolones. The difference with these drugs is, unfortunately, these have to have a metabolism that's very extensive, versus the benzoisoquinolones tend to be metabolized by other forms that don't necessarily require liver and renal function. But the aminosteroidals do require liver function to properly break down because it is a steroidal molecule which is more lipid soluble, but they're still very water soluble agents because of the nature of the ammonium compound inside them. Okay? If you look at here, this is Pavilon up here. Pavilon has a bis quaternary structure. It's got 2 ammonium groups inside of it. So that's Pavilon. If you look at the intermediate acting groups, this is vecuronium here. Vecuronium has a monoquaternary compound, which makes it a more of an intermediate acting. When you put, anytime you put 2 agents on there, 2 ammonium groups in it, it makes it long acting. Okay, because it's got a double binding site. It tends to be more enhanced, more potent. Versus the intermediate groups tend to be monoquaternaries. Okay? The good thing about aminosteroidals is they don't tend to release your histamine like you do with the benzoisoquinolones. You can see with rocuronium, which is in the bottom one, it looks very, very similar to vecuronium. Okay? There's slight differences down here with the molecule, but it's very similar to vecuronium. Now, steroid derivatives, which is aminosteroidals, you have the way they're actually eliminated. Kidney is 80% responsible for Pavilon's breakdown. So if you have somebody with renal failure, Pavilon's really not a good choice. If you're looking at rocuronium or vecuronium, those are more extensively hepatically metabolized and then renally excreted. Okay? And the duration of action of these monoquaternary compounds is 20 to 35 minutes, versus if you're using Pavilon, you're looking at a duration of action of 60 to 90 minutes, which makes it a long-acting agent. Pavilon is an aminosteroidal non-depolarizing agent, which is an ED95 of 70 mics per kilo, which is pretty high. It's available in solutions of 1 to 2 milligrams per cc. Usually it's in 2 milligrams what we use. The dosing is you give 0.1 milligrams per kilo, which is pretty much the same as you use with VEC. Okay? It provides adequate relaxation and intubation in about 3 minutes. So when you give Pavilon, you should expect to be ventilating that individual for at least 3 minutes until the muscle relaxation kicks in. What I personally do is I put a twitch monitor after the person's asleep, and I check the first twitch to see how good the height is. Why do I do that before I give the muscle relaxant? Because what? You get a baseline. Why? Okay. But actually, more important than that is that some people have Botox. And it's really disappointing when you do your twitch monitor and you got nothing. and then you proceed to intubate, and the person starts coughing on you. And you realize that the person had Botox put on all over the forehead, so now they get no twitch response. Or the other thing could happen is that your battery's dead and you don't know it. And that's another thing, very disappointing. You should shock yourself at that point. No, that's not fun. We used to do that for fun. We used to see how many people could take the 10 level. And the trick was you'd take a battery, put it in the refrigerator, and freeze it, and then put it back into your nerve stimulator. And the first time you'd shock yourself at 10, it wouldn't hurt so much. And then you would put it in your hand, warm it up, and then you give it to the next guy, and he'd jump. So, see, smart thinking. Okay? So, making a battery cold that doesn't lead to voltage decrease. So, little tricks like that make a difference when you're competing for money. Anyways, onset time is 3 to 5 minutes. Duration of action is 60 to 90 minutes. And one of the things that can really enhance the effects will be things like respiratory acidosis. You can sit here and memorize this. The reason I throw this in for you is just to have you have as a background. I don't want to torture you with memorizing everything. It just says when you get to clinical, you'll have this available for you. You can look it back on your notes, and you'll be able to find it very easily. Okay? This is your normal induction dose. It is 0.1 milligrams per kilo. That I expect you should know. And you should know that it takes 3 to 5 minutes to work, and you should know that it takes about 60 to 120 minutes or 60 to 90 minutes for it to wear off. Clearance is 80% of the single dose is eliminated unchanged by urine. So this is renally excreted. So renal failure decreases the plasma clearance of Pavilon by 35 to 50%. So it's really not a good agent of renal failure. This is why you would not pick this agent. If you have somebody with renal failure, it would not be a good idea to use Pavilon. Okay? 10 to 40% of Pavilon is metabolized to active metabolites. So patients with total biliary obstruction and hepatic cirrhosis will actually have decreased clearance and increased volume distribution. This needs a higher initial dose to have the same effect, but then the effect stays forever. So that's the downside to it. Cardiovascular effects is very profound with Pavilon. It increases heart rate by 10 to 15%, and you have a consequence an increase in cardiac output and increase in mean arterial pressure. The selective cardiac vagal blockade is an atropine-like effect limited to cardiac muscarinic receptors. It causes a marked increase in heart rate, which may result in altered AV conduction in some patients, including acceleration into AFib, which is a concern. So this is another agent that you may not want to consider giving to somebody who's already AFib or has a history of SVT in the past. Okay? It does activate the sympathetic nervous system, but where it's ideal to be used is when you're giving high-dose narcotics. High-dose narcotics will inhibit your sympathetics and will cause a bradycardia that will be very profound. But when you give it with Pavilon together, you get the reversal of the effect, and you get no change in heart rate. It's really cool. You give the two drugs together, and you get no effect. It's like, wow. Versus if you give vecuronium to that individual, which has no heart effects, you get a very profound bradycardia from the fentanyl, and you'll see an acute drop in cardiac output in somebody who's maybe already marginal. So Pavilon has its place when used appropriately. Be very, very careful by giving Pavilon and DIG together because they're associated with the incidence of very significant dysrhythmias. Okay? This is what Pavilon looks like. But where the Pavilon binds to it, it's just a bisquaternary compound. It binds here and it binds here, which gives it high potency. So its duration of action can be very long. Pipocuronium, very, very short, and I'll stop here in a few seconds, is a long-acting aminosteroidal. It's also a bisquaternary compound. Okay, it's got your ammonium group up here, and it's got the other one over here. Okay, so it has two sites of action. It's very long-acting. The actual ED95 is 50 to 60. The pharmacokinetics resemble Pavilon, and the onset's between 3 to 5 minutes and duration 60 to 9 minutes. The downside to it is it doesn't increase heart rate. So you don't get any of the benefits of a long-acting agent when you're using high-dose fentanyl. So for that reason alone, it's never been used in hearts. Okay, it's not a very useful agent. So because of that, we'd almost never use it. Histamine release and cardiovascular effects do not really occur, so that's why it was initially being sold as being the perfectly stable drug, but the problem with it is it's just too long-acting. And when you give this drug and it works 90 minutes, and I actually found that out the hard way. I was doing one of my first big cases for cancer, and the surgeon told me this to me. It was booked as an 8.5-hour case. Okay, so I told my attending, he said, "Can I use pipocuronium?" And he goes, "Yeah, sure." And it's like, because I was so excited. My first time I was going to use it, I give a whopping dose to intubate. I get the guy intubated in 3.5 minutes. Perfect, you know? The surgeon opens up the belly, looks in. I'm done. What? You're done? Yeah, you're done. Says, and they basically had metastatic disease everywhere, so we were done. So now I had to sit there for 90 minutes, and it worked till 90 minutes. And it worked the whole time, okay? So it's for that reason it burns you. My attending was laughing so hard. He said, I guess you're not going to be using that agent again. This is not for a while. So that was my last time I used it, actually. And I never found another use for it. I tried looking for other uses for it, but there's not many cases that last that long in the operating room nowadays, okay? The surgeons work very fast. They're efficient. Our gallbladders take 15, 20 minutes. If you give pipochloronium, forget about it. They'll hate you real fast. So what you're left with is the intermediate acting agents, which is what I'm going to talk about next. All right, so we'll go on to the intermediate acting agents now. There's two major ones that we're going to talk about, which is vecuronium and rocuronium. Both these agents are extensively liver metabolized, so these are the agents you don't want to be using in patients that have liver failure. They have similar onset of action when compared to long-acting agents, so it takes about 3 to 5 minutes for them to take effect, except for the exception to that is rocuronium. Rocuronium has very rapid onset. Okay, it takes about a minute, minute and a half to kick in. Okay, the intermediate acting agents have 1/3 the duration of the long-acting agents, so they usually work for about 20 to 35 minutes. Vecuronium tends to work a little longer than roc most of the time. It's usually around 40 minutes sometimes. And it's 30 to 50% more rapid rate of recovery than in comparison to the intermediate, to the long-acting agents. It has minimal or absent cumulative effects, which makes it nice if you can use it as a drip. And it has minimal or absent cardiac effects as well. Vecuronium is the first one. Vecuronium is a monoquaternary aminosteroidal. It has an ED 95 of 50 mics per kilo. Its intubating dose is 0.1 milligrams per kilo. Just the same thing as Pavilon. It's kind of easy. Okay, intraoperative relaxation can be done, this is the intubating dose, which is very high. Okay, it's 3 times the normal dose. Okay, so you can drop it down to 0.04 milligrams per kilo just to get adequate muscle relaxation once you have the person asleep. So you don't need the high doses. So that's what we tend to do. I usually tend to give 0.3 to 0.2 milligrams per kilo, usually once I have succinylcholine already on board, because you get the potentiation effect. Then once you get that going, usually we give it 0.0 milligrams per kilo every 15, 20 minutes, usually about every 30 minutes, what I tend to do, to make sure that you maintain adequate twitch height. Usually only need 2 out of 4 to get adequate muscle relaxation for surgical procedures. Okay? Some people will do infusions of 1 to 2 mics per kilogram per minute, which is fine. I used to do that in the past. It's just too much of a pain, so I just use bolus doses. It's actually easier for me. You'll find that you get comfortable doing different things. Once you get burned the first time of giving too much because you forget about it and you don't look back and you got now 0 twitches and you don't know how long you gave too much infusion, then that's when you'll just go back to bolusing again. But if you really are a Tiva fan, everything will be in drips for you, which is fine. You know, that's what makes you happy. Okay, the turnover rate is going to be a problem for you though. So you want to get rapid turnover on everything you do in medicine. This is the dosages. Again, you don't have to memorize that except for the induction dose, which is I expect you to know, which is 0.1 milligrams per kilo. Vecuronium has an onset time that's delayed, which is 3 to 5 minutes. The duration of action is anywhere between 20 to 35 minutes. And it is structurally related to Pavilon, but it's a monoquaternary, not a biquaternary. It's a little bit more lipid soluble and is a much more cardiovascular stable drug. The clearance goes both renal and hepatic clearance, but mostly lipid, because it's a lipid solubility. It requires more of the liver to get rid of it. Okay, about 40% of the drug is unchanged in the bile in the first 24 hours. The biliary tract is important for removal of vecuronium. Approximately 30% of doses is recovered in urine as unchanged in the first 24 hours. Renal clearance, elimination half-time of vecuronium is prolonged in patients with renal failure. So Vex is another drug that you don't want to give in patients with renal failure. Okay? So VEC is going to be affected by both liver failure and by renal failure. So again, this is one of those drugs you may not want to use for that. The patients with renal failure also seem to be more tolerant to the effects of VEC, and they get consistently slower onsets of action in comparison to other patients. Hepatic clearance doses of 0.1 milligrams per kilo are not associated with prolonged half-time with alcoholic liver disease because it's not considered a big enough dose, but you give repeated doses when you're up to 0.2 milligrams, then you now have prolonged elimination half-time and prolonged duration of action. It should be 0.2 milligrams per kilo. I'm sorry about that. So, but you have to go to the next step. Okay. This is what vecuronium will do. It gets metabolized by the liver into different compounds. Most of them are inactive. Some of them are partially active, so it has its own problems associated with it. So it does require a significant amount of metabolism to get rid of this drug. Acid-base changes, if you're changing CO2 that precede vecuronium, you do not really have any effect. But if you have hypercapnia after you've given the vecuronium, you can actually significantly enhance the effects of vecuronium, which is not a good thing because that's when when you want the effect to go away. It's when you're trying to allow that person to spontaneously breathe. That's when the vecuronium kicks back in and can surprise you. So that's why you should always reverse people because you didn't know if that effect is going to be stimulated by the hypercapnia. So hypoventilation could induce a neuromuscular blockade to take place again. And you may think that everything's fine, and in actuality, the person's getting more relaxed at the end of the case. The cumulative case is that vecuronium has large volume distribution leading to a rapid redistribution. With subsequent doses, vecuronium in various compartments will limit the distribution to the central compartment and subsequently decrease the clearance, but it has a cumulative effect less than Pavion, but greater than atracurium. So it can accumulate, but it takes a lot more dosing, usually like the 0.2 milligrams per kilo before you start seeing the cumulative effects. This is a nice picture I just wanted to show you. This is hopefully something that is going to come down the pike. The reason I show you this is because when you reverse somebody, most people think that reversal occurs right away. And that's nothing but the truth. That's totally not true. If you look at the bottom, this is what our normal reversal with neostigmine takes place. It takes 8 to 12 minutes for a reversal to take place. So when people tell you in clinical that you can actually, I can give a little bit of neostigmine and then I can get the effect I want, they're totally delusional. Okay? The way the drug works is you've got to push off and basically competitively push off by increasing acetylcholine levels at the neuromuscular junction to push off the non-depolarizing agent. And that takes time. Okay? And the higher the amount of acetylcholine you have, in other words, the more anticholinesterase you inhibit, the more rapid the effect is going to take place. So by titrating it in, you limit that effect. And you can actually make this curve even slow down even more. See the red line is that? That's somebody who's given a low dose and not given a good enough dose of neostigmine. So you really need to give your good neostigmine adequately to get your reversal. But one thing you want to notice is that this curve is gradual. This is a slope, which is not something you want for a reversal agent. You want something to push it off immediately. That would be the ideal. Something that I still don't understand why the FDA has done this, and they have not given a reason why they did it. They have this great drug called Sugammadex. Okay? Sugammadex is actually a sugar-like molecule that is basically like a donut. Okay? And inside the donut, it has a highly charged negative charge. So what's it going to do? It's going to take the positive charged molecules and soak them up. And most of our muscle relaxants are positive ammonium molecules. So when you give Sugammadex, it's like soaks up all this stuff all at once. It sucks it out literally out of the neuromuscular junction. Great drug. It reverses people, and you can see the effect. The effect goes, and this is Sugammadex on the top of the screen. You can see as soon as they gave the Sugammadex, the person had no slope. It was immediate reversal. That would be a perfect agent. This would make succinylcholine go away. If you could give something that you could reverse somebody so quickly that if you got into trouble and you had Sugammadex, you could give it and get yourself, your non-depolarizer, out of the system, it could possibly take away succinylcholine. Still, the onset time's too delayed, but what you would do is you would double up or triple your dosing of the non-depolarizer to get that rapid onset. You would literally shove the medication in there with high degrees of molecules. But then you could be able to scrounge it up with Sugammadex and get it out of your system. That was the original thinking behind it. So just as you hear about this drug, maybe it'll be in your practice in 5 years from now. This is like when I was told about Diprovan. We all got excited about it, but nothing happened for a few years, but all of a sudden it came out. When this drug comes out, it's going to be revolutionary in the way you reverse agents. Edrophonium, neostigmine will go out of the wayside, and all you'll be using is Sugammadex. Okay, so it's a kind of a cool named drug too, Sugammadex. Okay, okay. Give me some sugar, yeah. So, cardiovascular effects. Okay, most of the non-depolarizing agents are pretty stable, especially becuronium and rock. They're typically devoid of any circulatory effects. They lack any vagolytic or histamine release, and their modest vagotonic effect is suggested by an increase in incidence of bradycardia, but that's usually with very, very high doses, and usually it's associated also with injection of opiates. Absence of neuromuscular blocking drug-induced vagolytic effects may permit cardiovascular effects of other drugs, which is like I was saying to you, narcotic will cause a very significant bradycardia when you give becuronium together. Elderly patients, becuronium is associated with a decrease in plasma clearance, and as a consequence, they also have a less of volume distribution in the elderly, so you have a potentiation of effect when you're giving Bec to older people. That's why we tend not to give Bec too much to older people very much. Pregnancy, becuronium doesn't really cross the placenta very much. It's really not a problem, but the problem is that it can, the pregnant woman can have a prolonged effect. So something I don't recommend giving Bec to anybody that's pregnant. I don't think it's worth it. The surgeons are already used to not having muscle relaxation because they don't have it when they're doing a spinal. So they're very, very comfortable operating with the environment that they're in. So adding a muscle relaxant to that situation doesn't really help and just increases the risk. Just if you have to intubate them, do succinylcholine and move from there. Obesity, the duration of action of becuronium but itraconazole is prolonged in obese compared with non-obese patients. So. Now let's go on to rocuronium, also known as Zemiron. Rocuronium's gotten a really bad beef the last few years because people are finding out that when you redose this drug, it doesn't do what it's supposed to do. It acts way too long. So when you redose this drug, you may have a very prolonged effect. And that nobody's been able to explain what that is, why. So this has kind of hurt this drug, and a lot of people are trying to go away from it. The good thing about this drug is that the ED95 is pretty high. It's 0.3 milligrams per kilo, which is 30 mics per kilo. The onset of action is 1 to 2 minutes, which is very rapid. The duration of action is single dose is pretty consistent, around 20 to 35 minutes. And it is a monoquaternary compound, very similar to becuronium. It does have a little bit of lack of potency compared to Bec, and that's why we think it's important, because when you give this agent, you're giving greater numbers of molecule when you're administering it. So there's more chance of it to bind, which gives it a more chance to be more rapid in onset. The dosage on it on induction is around 1 milligram per kilo, so that's a huge dose increase. Think about that. Bec was 0.1, okay, and Roc is 1. So it's very weak in a sense, but the number of molecules that you have is in a 10-fold increase in molecules. And so you have a lot more of them that can now bind to the sites. Okay? You can see that your dosage drops down when you're already intubated to about 0.3 to 0.4 milligrams per kilo. Again, don't have to memorize this. Just memorize the induction dose. You do need to know those. Might as well start learning them now. And I'll ask you maybe 2 or 3 questions. I'll ask you like, match the following induction dose with the medication. Okay, so that's what I expect you to do. Rocuronium, after the administration of 3 to 4 times the ED95, the onset resembles the onset of succinylcholine. Roc is the only non-depolarizing agent that may serve as an alternative to succinylcholine with rapid onset. Okay, the downside to it is that it acts too long. It can act for 25 to 35 minutes. So that's a real downside. The downside also too is it seems to knock out the adductor pollicis first before it knocks out the larynx. that's the downside. Okay? This is what I was telling you before, the controversy between the different muscle relaxants that you have. Sometimes you have a muscle relaxant that will knock out the adductors first in comparison to the larynx. It's really preferable to knock out the larynx quickly so you can get perfect intubating situations. So what did Rock do? They did a study where they actually took individuals, I think they took 150 individuals, and then they set up a staging process, a scoring process, by which they determined how good the intubation was. Okay? And the optimal one was staged with a score of 3. A score of 1 was the worst, where you have severe coughing, bucking, vigorous limb movement. You see that with some drugs, and it's really irritating when you see it. It's like, you don't want to have that. People get stressed out in the operating room. The nurses in the actual operating room will tell you the patient's not asleep. No, it's not. Patient's not asleep. Patient is asleep, except they're just moving. Okay? It's a big difference. They're already induced properly. Okay? But most people, when they see movement, because they've been so used to using succinylcholine and so used to using all the other agents, that when you see a little bit of movement, people say that their person's awake. That doesn't necessarily mean that. Okay? You can have somebody totally unconscious and put a blade in their mouth, and they'll react and try to move their hand towards you. It does not mean that they're awake. Okay? But what you see is that with succinylcholine, you still get a much better intubation in the actual scoring compared to Rock. Okay? And you can see the biggest problem is in your poor scale, Rock is much more of a problem. If you look at your induction speed, how fast it is to be able to get down to 0 twitches, you're down to 0 twitches pretty much at 60 seconds with succinylcholine in almost 100% of your patients, versus Rock, you're looking at about 120 seconds, so almost 2 minutes before you get that almost to 100%. Okay? And that's what the limitation of this drug is. It's still fast, but not as fast as Sux. Rocuronium at large doses needs to resemble the onset of action of succinylcholine, but then you have to give very large doses, and then it acts more like very long-acting drug. Complete suppression of a single twitch of the adductor does not confirm paralysis of the diaphragm and laryngeal muscles, which is what I was telling you about before. When you give Rock to replace succinylcholine for an open eye globe injury, you think everything is gone, and you find out when you put the blade in that the person starts coughing on you with disastrous results. Okay? That's why it's also not such a good drug in that respect. Conversely, initiating laryngoscopy at the time of peak laryngeal muscle spasm could result in abdominal movement and result in aspiration. So you've got to pay the price somewhere along the road. I just pay the price with succinylcholine. I think it's just safer. Clearance is largely excreted in the bile. Okay? Renal excretion maybe 30% in 24 hours, just like vecuronium is. And still the liver is big responsibility of breaking down this medication. Cardiovascular effects is the release of histamine does not follow the rapid administration of large doses of Rock, so for that reason it is safe to use doubling doses to get the effect you want. It has some degree of vagolytic effect, so you actually can sometimes see an increase in heart rate. But it's also maybe useful when you're doing open eye injuries if you want to eliminate the vagal reflex, the octocardial reflex, because it acts a little bit like atropine in its action. The increased onset of action, Rocuronium may serve as an alternative, but with rapid onset is required. But again, be careful. Make sure that the person is really fully muscle relaxed. Speed of onset of other intermediate acting agents can be enhanced by doing what's called a priming dose. I've done this, and I do this with atracurium as well. Is you give 10% of the ED95 of the drug, and then you follow it with 4 minutes later with the larger dose, which is the normal intubating dose, which is 2 to 3 times the normal ED95. And the thing is, then you get a very rapid onset. The downside to that is sometimes you already get, with some people, with 10%, you already get a partial paralysis, and people start freaking out. So that's a little bit uncomfortable, to say the least. Neuromuscular blockade of intermediate actions are reliably blocked by anticholinesterase drugs, often within 20 minutes. So you can reverse the effects very easily if you want to. Now the next set of drugs, and we'll finish up on this section, will be benzoisoquinolones. Benzoisoquinolones all have acurium in them. So you have atracurium, cisatracurium, the intermediate acting agents. Okay? Then you have the long-acting agents such as doxycurium and tubucurari. and you have mivacurium, which is a short-acting agent. What's interesting about benzoisoquinolones is they have different elimination mechanisms than other drugs that we've talked about so far. The actual atracurium breaks down by Hoffman elimination, as well as cisatracurium breaks down by Hoffman elimination. What's interesting about atracurium is most people just think that it breaks down by Hoffman elimination, but it also breaks down, in a majority of it, by ester hydrolysis. Okay? Hoffman elimination is part of the metabolism, but not a majority of it. The one that is purely Hoffman elimination is cisatracurium. So that would be a great test question. Hint, hint. Okay? Okay? The duration of action is pretty predictable with atracurium and cisatracurium. We're looking at 25 to 35 minutes on atracurium and 25 to 44 minutes with cisatracurium. The doxycurium is the first one, which is the long-acting. We're going to go from the long-acting to the intermediate to the short-acting, which we'll finish up on mivacurium. Neuromax has an ED 95 of 30 mics per kilo, okay, which doesn't make it very potent. Pharmacologically very similar to Pavilon. It's not associated with histamine release or cardiac effects, which is kind of nice, but it's too long of action, may occur with elderly, so for that reason it's not used very often. Europeans still use this, but in the United States I haven't seen doxycurium in the last 3 years, so something I'm not going to ask you too much about. This is the drug I expect you to know a lot about because it's the one we're going to use a lot in your practice here in a lot of places. Atracurium is a benzoisoquinolone non-depolarizing neuromuscular blocker. It's a bisquaternary compound, so it has 2 quaternary groups. You can see them here. Okay. It has the normal induction dose is 0.5 milligrams per kilo. Okay, and the way I do it is I do a split dose. If you give the 0.5 milligrams per kilo in one shot, you're going to get a lot of histamine release. So I give 0.25 milligrams over 2 minutes apart. So I give 0.25, give my induction agent. I give my induction agent first, then make sure I can ventilate. Then I give 0.25, wait 2 minutes, and then I give another 0.25. And that way I don't get any hypotension from the histamine release. If you give the full 0.5 milligram dose, you're going to get histamine release, and you're going to get profound hypotension in some people. Duration of action is 20 to 35 minutes, and the onset of action, like almost all the intermediate acting agents, is around 3 to 5 minutes. Okay, this is again what I expect you to memorize is in the middle here. 0.5 milligrams per kilo is your induction dose. Atracurium is unstable at normal pHs. So one of the things that is done to the medication to keep it in solution is to keep it at pHs of 3.25 to 3.65. The other thing that you have to do with atracurium that you don't do with other drugs is you have to refrigerate it. If you leave it out and not refrigerate it, it starts to break down. If you leave the medication in your drawer for 30 days, it's gone. So it's really not very useful at that point. So I don't recommend you leaving atracurium there all the time. You should keep pulling it out every once a week, and you should be okay. The danger of atracurium is that if you mix it with thiopental as you're giving it, it'll precipitate out. And that's something you don't want to do. It basically inactivates the drug. So what we used to do was we'd give the sodium thiopental, then wait several minutes, or flush the line with saline, and then dose the atracurium following that. And you look for any white crystallization that's taking place, which is what you want to avoid. Atracurium, also known as tracheum, is 82% bound to protein, which is mostly albumin. It acts both at the pre- and postsynaptic cholinergic receptors and may affect the passage of ions through channels and nicotinic receptors. So it is a very potent agent in that sense that the good thing about this agent, it does wear off very quickly. Clearance is 1/3 of the metabolism is by Hoffman elimination. Okay? Most people have this wrong in their mind. Most people have, for some reason, they say atracurium is 100% Hoffman eliminated. That's not the case. Only 1/3 of the patients of the actual drug is actually broken down by Hoffman. Hoffman is basically doesn't require any kind of enzymes or anything. It's just basically a spontaneous reaction that occurs in normal pH and normal temperature. So if you make the temperature go down, Hoffman elimination slows down. If you make the person get febrile, the medication breaks down faster. If you make the person acidic, this is kind of controversial. I'm going to give you 2 answers. Normally, if your acid levels go up, okay, Hoffman elimination slows down, okay, which is not good. But with atracurium, you get the benefit of when you go up in acidity, ester hydrolysis increases. So that will overpass the effect, which is 2/3 of metabolism is by ester hydrolysis. So when you let somebody spontaneously breathe and their CO2 levels go up and they become more acidotic, they metabolize the drug faster. Okay, versus cisatracurium doesn't do that. Cisatracurium actually slows down its metabolism at that point, and it could be a problem. Okay, because that's only ester hydrolysis driven. Only Hoffman elimination driven. So this drug has two combined effects. Sometimes they call this the Hoffman part of the elimination of atracurium as a safeguard of that medication. So in case you have other problems with ester hydrolysis, you still have the medication still being broken down. Okay? The two routes are independent of renal and hepatic function, which makes it nice. When you're giving atracurium with somebody with renal failure or liver failure, you don't have to worry about it. It works just fine. One of the major metabolites of atracurium is ladonosine. Ladonosine has no activity at neuromuscular junction, but has, if you're given it allowing for very high concentrations, which is very, very rare and something that's not even clinically important, may induce seizure activity. So I've never seen anybody get seizures from atracurium. I think it's a theoretical concern. The only place you could possibly see that if you were giving in the ICU for prolonged days of this. So in the operating room, it's not going to happen. The other thing you also have is one of the breakdown products is called the electrophilic acrylates, which are unknown as to what they do. They actually are known to cause damages to cells, but you don't see any real extensive damage when you give atracurium to people, so it's really a questionable clinical significance. This is the actual metabolism of Hoffman elimination. 1/3 goes via Hoffman, and the ester hydrolysis goes the other way, which is 2/3 of the metabolism. Cumulative effects. Consistent onset of recovery after repeated supplemental doses makes this drug very useful of using as a continuous drip. Okay? Atracurium is actually used extensively as a continuous drip medication. The nice thing about giving it continuously, you tend to get not the histamine release as much. One of the things that you can affect is you can get hypotension and tachycardia, and usually if you give excess of 0.5 milligrams per kilo because you're giving the histamine release. It may also cause a transient fall in SVR, again, from the histamine release. The way you can slow this down is to slow the rate of injection or give split doses, which is what I tend to do. Be very, very careful about using this in asthmatic patients. You should not be using it in asthmatic patients. Okay? Duration of action may be prolonged in hypothermic or acidotic patients if it's totally Hoffman eliminated, but in acidic environments help ester hydrolysis and may speed induction metabolism. So for that reason, atracurium is kind of helpful in the sense at the end of the case, you can allow the person to spontaneously breathe, and you can accelerate the ester hydrolysis and in effect make the person break down the medication faster. Cisatracurium is the next drug, Nimbex. Okay, it's also benzoisoquinoline, non-depolarizing agent. It's a bis-quaternary molecule. CD95 is around 50 mics per kilo. Its onset of action is 3 to 5 minutes with a duration of action of anywhere between 25, 30 to 44 minutes, depending on which book you read. It's very similar to atracurium, but it has some differences. There's less propensity to release histamine with this drug, which is why it was being sold. It has slower onset of action, which is a downside to it, but has prolonged cisatracurium infusions is not associated with prolonged effects, so that's kind of nice. So cisatracurium has its usefulness. It undergoes only Hoffman elimination. This is one of the only drugs that actually undergoes only Hoffman elimination. The non-specific plasma esterases are not involved in metabolism, and the renal elimination is partially involved with elimination of cisatracurium, so you do get some clearance by the kidneys, but not enough to be a problem if you're in liver or renal disease. Okay? It is a little bit more potent, but it takes a little bit longer to produce. Less ladonosine is produced with cisatracurium than with atracurium. The dosage of it is usually around 0.15 to 0.2 milligrams per kilo for intubation doses. That's what we usually do. The breakdown is purely Hoffman elimination. So the downside to this drug is if you let the person spontaneously breathe and you let the person become acidotic, you actually slow down their metabolism. Hyperthermia will make the person break down this medication faster. Hypothermia, on the other hand, will slow down the breakdown of the substance. Cisatracurium is pretty much devoid of histamine release if you keep it under the normal 0.2 milligrams per kilo dosing. But if you give higher doses, you can get into trouble. Okay, it says it doesn't really occur even after. I would disagree with that. A lot of people would disagree with that. You can see that, and it's written in the book. I didn't agree with that statement, but my opinion would be that if I've seen cisplatin cause histamine release when you give it at 0.3 milligrams per kilo. So you really got to stick with the 0.2. In patients with coronary disease, cisplatin is indistinguishable from becuronium, which is pretty effective. The last drug is mivacurium. Mivacurium is a short-acting benzoisoquinolone. It is a bisquaternary compound as well. Its ED95 is fairly high, 80 mics per kilo. Its onset is 2 to 3 minutes, which makes it very rapid in onset for a benzoisoquinolone. Its duration of action is 12 to 20 minutes, and the duration is approximately 2 times that of succinylcholine, and has intermediate activity in comparison to other neuromuscular blockers. One of the things that I have a problem with it is that when you give it at high doses for induction, you can get a very profound histamine release, which is a real problem. Okay, the dosing on this is about 0.2 to 0.25 milligrams per kilo on induction. It consists of 3 stereoisomers. 2 of the isomers are hydrolyzed by plasmacholinesterases. So this is one of the few drugs that's actually broken down pretty much by plasmacholinesterases. The clearance increases with increasing dosage, so you got to be real careful with that. Hydrolysis is decreasing the presence of atypical cholinesterases. So if a patient who has atypical cholinesterase, you can have a prolonged effect, just like succinylcholine. And mivacurium does produce an intense neuromuscular blockade. If you give somebody, if having problems with this drug's not wearing off, you can give FFP just like you do with succinylcholine. And anticholinesterase drugs are really not effective in reversing this drug. This is the actual compounds that are made. They're broken down by different hydrolysis and mostly plasmaesterases. In renal dysfunction, it appears a minor pathway for clearance, so you can use it in renal diseases, not a problem. Hepatic dysfunctions really can be an issue if you have pseudocholinesterase deficiencies, and in that case, you can have a problem with this drug. And you need to avoid it in asthmatics because it causes a significant histamine release. That's really why it went off the market. Okay, it caused too much histamine release. It was a nightmare. Okay, and when you try to use it when high doses, you couldn't do it. In 2006, Abbott Labs took mivacurium off the market. Okay, so I don't know. I think you just still need to know a little bit about mivacurium for your test, but I'm not going to really harp on it. The induction dose I'm not going to worry about. What I'm going to ask you about it is how is it broken down? Okay, what was it supposed to replace? Why didn't it replace it? And the answer is histamine release. Okay, so this is the kind of things I'll ask you because I think they might throw that drug still in there, although it's not used anymore clinically since 2006. So maybe it won't be used anymore on your exams. Maybe we'll take it off in the future. Pharmacological antagonism. We'll talk about that in the next lecture, so I'm going to skip through this. And one of the things that you do have to know is that in muscle denervation injuries, like somebody with upregulation, they tend to be more sensitive to depolarizing agents and resistant to non-depolarizers, versus if you downregulate, like in a person with myasthenia gravis where they have destruction of the acetylcholine receptor, they're resistant to depolarizers and they're sensitive to non-depolarizers. Okay? That's a typical board question, so you need to know that one. Okay? So make sure you memorize that last one. Now, I'm not sure I have enough time. It's really not really enough time, I think. Yes, do you have a question? Yes, that's what they tend to say. Yep. The question is it really true? And the answer is it's really not very true most of the time. Most of the time that you're getting the allergic reactions to is the antibiotic. So antibiotics really have a high incidence. But you'll see that written in the literature. The literature says that it's the muscle relaxants that are causing it. I have a hard time believing that. I've been giving muscle relaxants for 20 years. And when you give it appropriate doses and avoid the histamine release, then it's usually not a problem. They call it allergic reaction to histamine release. I don't consider that allergic reaction. That, to me, is not an allergic reaction. It's you gave too much of the drug. Okay? So if you want to count that as an allergic reaction, then it does happen pretty often. To me, an allergic reaction is an IgG-based antibody that when you give it in repeated doses to somebody, you get a very severe histamine release. So I've never seen that too much. I see it when I screw up and I give too much of a dose. Okay? And you should ask those docs or whoever you're working with to use split dose. And their answer will be usually no. Or they won't know what that means. Okay? Split dosing is something rather new. It's been out for about 5 years, so if they haven't been reading the literature, you'll see that the person will not tell you anything about split dosing. Okay? But split dosing can really make a difference. It reduces the histamine release by almost a third to a half. So patients that are in profound shock, hypotension, giving them histamine-releasing drugs is very dangerous. So you don't want to do that. So in somebody with trauma patients, you never would give a benzoisoquinolone. You'd give the aminosteroidals, ROC or VEC, after you give succinylcholine. So, but anaphylactic reactions are really IgE or IgE mediated or IgG mediated. So it's an antibody reaction. I had one patient, at least I've had 3 patients in my career that other physicians said that they had an allergic reaction to the actual muscle relaxant. I took the same muscle relaxant and used the same muscle relaxant and had no effect. And why did I do that? Because I'm ballsy? No, because I looked at the dosing. They gave twice the amount that I gave. So they got profound histamine release. That's different. Yep. And you see what they dosed. A lot of people tend to be very, very heavy-handed with muscle relaxants. Okay? They tend to be very heavy-handed. You got to go easy on some of the stuff, especially the benzoisoquinolones. They tend to be really problematic drugs. The aminosteroidals almost cause no histamine release at all, and for that reason, they're really very useful. Okay, you can go with high doses of those drugs and be very safe on intubating rapidly without really causing any kind of bad effect. If you try the same thing with atracurium, you do a doubling dose, which is to potentiate the onset of action, you're gonna get burned. Okay? And what you need to do is you need to play with these drugs. You got to give a dose and see what happens. Read about when you get a chance before you get to clinical. Read about split dosing. It's an interesting discussion. So, just like if you see people with morphine, right, and they see the red streak coming up the arm after they give them morphine, what does everybody tell you it is? It's an allergic reaction. Almost everybody will tell you it's an allergic reaction. It's not. It's histamine release. So you have to separate the terminology. And unfortunately, the literature is that way too. The literature doesn't explain the terminology adequately. So people throw in histamine-releasing reactions as being allergic, which is not the same thing. Okay. All right. What I think I'm going to do is, we got 20 minutes, or I got 10 minutes. Let's see. You guys want to quit, or you want to keep going? I shouldn't ask you that, right? Dr. Nolan, you should know better than that. You're already stuffing enough in my head. Let me look at this quick. It's amazing how much stuff you have to learn, huh? You know what I'm going to most likely do is I'm going to throw chapter 33 out, and I'll just move this lecture down to here, and move these 2 last ones here. And there'll be one less chapter. So I don't think they're going to help. Okay. All right, I'll take a look at it and see what I can do. Okay. But next week we'll start on the monitoring of neuromuscular blockers. This is all animated. Let me just give you a real quick. I'm just going to give you a real quick brief, sort of give you an idea. So, and then we'll start back up. I'm just going to go to the animation slide. All right, this is what the phase 1 mechanism looks like. Because somebody asked me about what happens. Okay, In phase 1, you're going to only bind to the postsynaptic receptors. Okay? So what you see is when you twitch, okay, the person releases 4 vacuoles for every time you twitch. Okay? So you get the same muscle height contraction. Okay? So this is a person who's not muscle relaxed, and every time you twitch that person, you get 4 vacuoles being released. Now, the same thing will happen with post-tetanic, but this time when you give post-tetanus, is now you relieve residual acetylcholine, so the next one is accentuated, and you get what's called fade. That's a normal reaction, okay? Because when you give tetanus, you cause a tremendous increase in release of acetylcholine. Okay, so the next twitch height is already going to have, instead of having 4 molecules of acetylcholine out, it's going to have 6. So you're going to get a potentiated effect. Now, when you fully depolarize somebody, when you give somebody succinylcholine, here's what will happen. Here's your succinylcholine. It binds to all the receptors. Now, when you give a twitch, nothing happens. You get no effect. Okay? So that's a phase 1 reaction that's really pretty high. Now, if you go to the next person where you have the 90% block, now you're going to get 1 binding, and you're going to see every time the binding is going to take place in the same site, but it's going to cause it to fire. Okay, you don't have any fade in this individual, but you still get twitch heights. As this begins to wear off, okay, now you have more opening sites, so now you get more greater twitch height. Eventually, you get no fade again. Does that make sense so far? Okay, let me just go on. We'll come back to this in more detail next week. Now, let's go to phase 2. Phase 2 works at a different site. Phase 2 works in these yellow sites, which are the presynaptic receptors. Okay? So when I give this person an agent, now it binds to it. As soon as the channel opens, it goes up and inhibits the vacuole release. So now instead of releasing 4, now I'm releasing down to 2 now. And the last one, because you've got so much calcium bound that you can't release any more vacuoles. Now you only have 1 acetylcholine. So that causes the fade effect. So fade is a presynaptic binding site effect. Okay? If you understand that, you've gotten way ahead of most people. Okay? Because this has just recently been understood in the last 2 or 3 years. Okay? If you look at phase 2, post-tetanic non-competitive block, okay, what happens when you release the first one, you still get extra release, but you get fade because you're binding to the calcium channel, so you still get fade. So the next 2 causes this detrimental effect on your tetanus. Now, as you go on to the next phase, when you do your twitch height, you now have full effect, but you don't get you get fade again from happening. So you do get fade with. You do get some potentiation, but you do get fade. Okay? All right, so we'll stop there. That gives you just an idea, and we'll come back to this later on. Okay? Hopefully that'll help you guys understand it, because the book is it's difficult to understand. Okay? Have a good day, guys.